Symposium 2025. Looking back at the history of the symposium, I was trying to count. This is going to be 21st annual Kropp Symposium. So a great tradition in the program. Typically, it is Dr. Kropp's family foundation that started this, as most of you in the room know. Dr. Kropp is a doyen in the field of urology and pediatric urology especially. Dr. Kropp is a person of science, and he always promoted scientific thinking, always wanted to make sure that all of us critically thought through problems. And I was recounting Dr. Kropp's favorite sentence for the residents was, "Put your thinking hat on." So anytime, whether you're in surgery, you're stuck at a step, if you're not making progress, or whether you're having a clinical diagnosis and you're having difficulties thinking, and he'll say, "Put your thinking hat on. Let's go through this one by one, and then we'll reach the conclusion or the possibilities." So continuing that tradition of critical thinking, Dr. Kropp promoted this educational activity where typically we'll have people come and invited in different fields, but always his first love was pediatric urology. Dr. Kropp graduated from Northwestern University in 1961, completed his residency in Northwestern University in 1966. He served in the United States Army, and then he came here, started the program. At that time, it was called Maumee Valley Hospital. From 1967 to 69, he was associate professor, and then he took over as chair of the program. He was one of the longest serving chairs of any urology department in the country. So that speaks volume about his nurturing attitude, his focus and attention he gave for growth of the residents in the program. He kept the program very focused. He made sure the residents, when they graduated, that they were fully equipped, and made sure that not only did they have a good knowledge base, but also a very good surgical skill set. I remember coming back from one of the conferences, kind of distraught junior resident, and telling, "Dr. Kropp, in such and such program, they do 50 radical cystectomies, and how come our numbers are so low? Why can't we do it?" And he said, "Puneet, all you need to do is one good case where you know every step, how you're doing it, why you're doing it, and doing it correctly. That's what matters rather than the numbers you put on your paper. It was a great advice, and I took it to heart. And I really, as attending, I come to realize it's not the numbers, it's how you own that procedure, how you do that procedure, how you think through one diagnosis that takes you where you need to be. We were so lucky to have him as our chair. Recently, we were together in his celebration of his 90th birthday, and so many stories were recounted. All of them have one theme to it, that what a kind-natured person he was. And I can't impress on you enough, that culture of kindness has percolated through the program, and we have made sure to keep that alive. Our residents are given full opportunity to show their full potential. This place has been great, and that's all. Thank you to Dr. Kropp and Dr. Kropp's family. I want to acknowledge Mrs. Sharon Kropp. We are so thankful to you. You made so much effort to have him be present here, and all that you are doing to promote this Kropp Symposium. So let's give them a big hand, please. So we're going to get started with our symposium. The first thing is we are lucky to have our Dean Imran Ali. And Dr. Ali has been here and knows the history of MCO, MUO, and UTMC now. He brings in a wealth of knowledge and compassion and his dedication towards our institution and the medical education. And Dr. Ali, please. Thank you so much for coming.
Thank you very much, Dr. Sindwani. And on behalf of the College of Medicine, I would like to extend a warm welcome to all of you, our speakers, as well as all the attendees here today. Dr. Sindwani asked me to say a few words, and I'll keep it very, very short. What he talked about, the legacy of urology, is truly remarkable. When I started working here a very long time ago, almost 30 years ago, I think urology was a powerhouse even at that time under the leadership of Dr. Kropp and a few of the other stalwarts that were in the department. They were nationally recognized educators and leaders, and that legacy has persisted under the leadership of Dr. Sindwani. We have absolutely wonderful faculty who do amazing work, train a significant number of our medical students who become interested and then take urology as a career choice. And if I remember right, Dr. Selman used to talk about it about 20 years ago, there was a paper about the number of recruits that UT had for urology, and it was #1 in the country. So clearly there's a lot of good work going on, and obviously everybody in this room at least, or at least most of you would know about our successful transplant program, but there are other areas of expertise and excellence that we really are very proud of. So Dr. Sindwani and your team. Right. If you see smoke, there is a problem, yeah, so.
Thank you, Dr. Ali, for your valuable time and coming to greet the visiting professors and our audience. It's not on the agenda, but I would like for all you to meet our Executive Vice President of Clinical Affairs, Dr. Charles Callahan. He is fairly new here, so some of you have already met him. If you're not, he is giving the direction of clinical affairs to our enterprise. Dynamic personality, wonderful speaker. We're glad to have him, and I want to make sure that everybody gets to see him and know him. Dr. Callahan, please.
Thank you, Dr. Sindwani. That was more than gracious. Thank you very much. As he said, I'm Chuck Callahan. I'm new here. I think I'm in my 5th month, and I come from, interestingly enough, Springfield, Illinois. So I've been at the Memorial Health System for a number of years and got to work with the faculty of the medical school there. Since I've been here, I must say the rich tradition of medical education, innovation, and service to the community has just been profoundly impressive to me. And so on behalf of the 3,000 colleagues of University of Toledo Health, we look at this as a dyad partnership. We want our management team, our clinical team to work closely with our medical staff, our medical professionals. Dr. Sindwani's the chairman of our medical staff, the elected president of the medical staff, been very welcoming and helpful to me. And there's a lot going on in healthcare. They say calm seas don't make for a skilled mariner. So I think all the choppy seas around us are making us very skilled, and I'm really confident for the trainees that come out of this program are going to be very well prepared to lead and to heal as they go forward. So enjoy your day. Thank you to Dr. and Mrs. Kropp for their support of this wonderful symposium. Thank you very much.
Those of you who were able to attend the WebEx event or in-person event yesterday and the day before about professionalism. I don't know if you heard our dynamic speaker and the medical and staff development first lecture by Dr. Eric Carlston. He's oromaxillofacial surgeon by background, very well accomplished in his field, and we are glad to have him at UTMC. And Dr. Carlson, I'm going to put you on spot. I know once again you're not on agenda on the program, but if you could please come here and say a few words. We are glad to have you. And I think I was blown away by the story you shared about your exposure to some of the things as physicians we don't pay attention to. Because all of us in surgical training in those days have gone through similar experiences that you shared. But at that time, we didn't have recourse. We didn't have anything different. We didn't know anything different how things should be done. So I'm very impressed by your vision, how you want to change the culture and inculcate those professionalism values here. Thank you for being here.
Thank you, Dr. Sindwani. Good morning, ladies and gentlemen. As the Associate Dean for Faculty Development and Affairs in the College of Medicine and Life Sciences, I look out at this audience and I read this program and I see Dr. Sindwani here and Dr. Callahan and Dr. Ali, and it just makes me feel really good that academic medicine is alive and well. To the Kropp family, I thank you very much for supporting this event. Thank you for the opportunity to be here, Dr. Sindwani. I wish all of you a great day in the spirit of scholarly activity in academic medicine. So thank you very much.
The first speaker, in the spirit of pediatric urology, as Dr. Kropp's vision was to promote the urologic health in the children. And those of you in the audience who might not know, there's a procedure which was described and mentioned for bladder neck reconstruction. It was called Kropp procedure. It was a great experience that one of the in-service exams, one of the field questions while we were sitting was about Kropp procedure. And you felt so privileged that you got to train with the person who devised this procedure. So am I touching something? The slides are moving forward. Sorry, Dr. Matthews, if that's happening. Must be. Okay. So our first speaker is Dr. Ranjeev Matthews. Dr. Matthews is Director of the Pediatric Urology at Southern Illinois University. He's also Residency Director, very well published, very well known. After doing his training at UMDNJ, he went to SUNY Upstate for his residency and his fellowship in pediatric urology at Johns Hopkins. Last night we were having dinner and chit-chat. It's a small world indeed. Dr. Matthews and Dr. Atiamo knew each other way back days when Dr. Atiamo was a resident, and the connections between all of us this morning, Dr. Callahan got to meet Dr. Matthews, and they go way back and they know each other from there. So we're so glad to have Dr. Matthews as our featured pediatric urology speaker. Thank you, Dr. Matthews, for coming.
Well, good morning. It's truly an honor to be here. Among friends, Dr. Sindwani I've known from the IAUA. Ahmed Azwari was one of my partners in Springfield. And it's truly an honor to be able to present in front of one of the doyens of pediatric urology, as Dr. Sindwani had said. You know, it's the one amazing thing about pediatric urology is that we actually get to meet our heroes. And I've been incredibly privileged from my time at Hopkins to be able to work with people like Dr. Jeffs, who initially started the extrophy reconstruction. And what I'm going to speak about today is an effort to bring what we learned to parts of the world that are terribly under-resourced. And while, I'm sorry.
Sure. This is being telecast live on YouTube, so the audio.
Of course. Yep. And so the goal has been to try and bring extrophy surgical reconstruction to the wider audience in the world. And while I'm going to take credit for this, I got to tell you that this is not work that I can accomplish by myself or have attempted to accomplish by myself. This is a team that has done this. I don't really have any disclosures. I am a board member for the Association of Bladder Extrophy Community. This is really a team effort. So the content that I'm presenting is really for this amazing team. So how did this all come about? I'm going to talk about how we developed the team, what have we done so far, and what really is the long-term plan for this. So in May of 2018, at the ABEC Executive Committee meeting at the AUA, the ABEC had been taking patients to India for surgical management by a surgical team that has been going to India. They'd been funding children and physicians to actually be transported to India and stay while the child recovered. But it was becoming increasingly cost ineffective. And so, of course, being who I am, I said, well, why do you need to transport patients to India? Why don't you just do this in Africa? Of course, everybody in the room turned around and looked at me, suggesting that perhaps, well, if you suggested it, maybe you should be the person doing it. So, of course, now I had stuck my foot in my mouth. And so I decided that, yes, I was going to commit to this mission to Uganda. And I think it was important, really, at the outset to make sure that there was going to be long-term sustainability. And I feel very strongly about this concept that really we should be educating people, if that's our role, to take care of their own patients, not going there doing operations and then leaving, but not leaving them with the resource to continue that work on a long-term basis. So in October of 2018, so this is just to show you what was being done. This is actually Dr. Satuma, who I'll talk to you about in a minute, and Emily, who's our clinical psychologist. They were in India with one of the patients that had extrophy reconstruction in India and then went back to Uganda. So in 2018, we traveled to Uganda, met with Dr. Satuma, who is a pediatric surgeon in Uganda, and Dr. Stephen Wacha, who had his own hospital. It was called Urocare Hospital in Kampala. We also toured facilities at their local hospital. It's called Mulago. It's a very large institution in Kampala, has its own urology services, including pediatric urology. And so we determined the mission to be, it was important to train physicians how to manage extrophy using really the safest, most successful management strategies. Understand we were moving into an under-resourced situation. We wanted to train them for care that was similar to what could be provided in the United States. And I know that seems like a lofty goal when you're trying to train people in an under-resourced environment. But I'll put it to you that should be where the goal should be. Training should be provided by experienced surgeons, nurses, social workers, and not really trainees. So we did not want to take any trainees with us over there. The outcomes would need to be evaluated and followed because we wanted to ensure that they were getting similar results to what we can achieve in the United States. And it needs to be sustainable. It needs to be a sustainable level of care, since extrophy is really a lifelong entity. It requires lifelong care strategies. And then part of what has happened here in the United States is that there is a community of children and parents who have sustained each other over the course of time. And we really wanted to be able to generate that similar community despite it being in somewhat of an under-resourced environment. So in 2018, we determined that we should really partner with Urocare. Again, we had very little experience in Africa from a medical perspective. Doctors Wacha and Satuma were very interested in learning and then teaching extrophy care. The facilities at Urocare were more likely amenable to providing care that was similar to the US, while Mulago Hospital is an incredible facility. They are significantly under-resourced, even more so because they are supported through government support only. So it was going to require significant financial support from ABC for supplies, hospital stay, etc. But we felt we could treat more children with the same funding that they were already providing for transporting children and families to India. So Dr. Wacha is the gentleman with the blue checked shirt. He's the person that owns the hospital. The other two individuals there are their social work services, wonderful social work services, and then Dr. Satuma. So this was the group that we were going to be working with in Uganda. There are some unique challenges with regards to extrophy, unlike what you see for many other entities. And perhaps you can extend this to anorectal malformations or things that require lifelong management strategies. Extrophy requires multiple procedures, each with unique challenges over multiple years, requires not only open surgical skills in urology, but it also requires orthopedic skills, anesthesia skills, and really, most importantly, a critical nursing care for success. And some of these procedures require prolonged hospitalization and post-surgical rehab. And so this is just, for those in the room who may not have seen an extrophy, this is a female patient with extrophy taken from our book chapter. This is a male patient with extrophy. So typically the initial closure of extrophy is done with osteotomies. The goal is to put the bladder deep into the pelvis. It does require a protracted hospital stay, typically 4 to 6 weeks. And if they are redos, it could be 6 to 8 weeks of management strategy. This is obviously one of our patients in Uganda showing the pins in place for the sponcellar osteotomy. The second step is an epispadias repair, where we bring the opening of the penis to the tip and rebuild the penis. And then the third step is continence. It's based on bladder growth, and the best determinant that a bladder is going to grow successfully is secure initial closure. In the US, this is typically performed around 4 to 5 years of age. You really need the family well prepared, and this is where, things like augmentation cystoplasty, bladder neck closure, those sorts of things come into place. So what was I looking for in a team? So we needed to commit to a long-term mission. We needed expertise in the field of urology. They needed to share the same Hopkins ethos about the management of exstrophy. And preferably, people that had trained at Hopkins would have been ideal. And remember, Dr. Jeffs, who passed away, but Dr. Jeffs was the person that developed the management strategy for bladder exstrophy. We also wanted people who could understand that there were challenges in working in an under-resourced environment, but still had to try to maintain those standards that were very similar to what we see in the US. So Pamela Artigas is the head of ABEC. Janet Gibson, she's actually lived in Uganda for 10 years before we went there. And so Janet was ABEC's coordinator, but she has a profound experience in Uganda, which was very helpful. Anthony Schaefer was one of my residents at Johns Hopkins. He's currently an associate professor at University of Utah, and is a pediatric urologist. And really, Anthony does the lion's share of the work of setting things up for our trip. Marlo Eldridge was my nurse practitioner at Johns Hopkins. She's still at Johns Hopkins. She's still a nurse practitioner and has probably more experience in managing bladder exstrophy than many urologists in this country would, because she has been doing this for 30 plus years now. And then Emily is one of the, Emily Hadid. She's a social worker, but has a huge experience dealing with families and has actually managed the entire social work services in Uganda. So where is this where is Uganda, for those who have considerations with geography? You can see Uganda is that orange spot there, and it's in a very tough neighborhood. It's tough from a perspective of their president has been president for the past 30 years. He's expecting to actually transfer the presidency to his son, who is also the head of the military. And you know Uganda has had a rather colorful past with people like Idi Amin, who was in power. You can see Somalia is essentially a failed state. It borders Uganda, Kenya, Tanzania. The Congo is currently in the midst of somewhat of a localized conflict, where Rwanda, which is one of those two little countries below Uganda, has been supporting rebels in Congo. And then you can see Sudan is just north of Uganda, and Sudan is now a completely failed state. So you can see it's going into an area that is somewhat challenging from a political, and South Sudan, which is the newest country in the world, is now also very rapidly falling into becoming a failed state. Our patient population actually comes from all of these countries. And so sometimes for patients to travel from South Sudan, if there's no fighting, it takes them about 12 hours. If there is fighting, it takes them more like 24 to 26 hours to get to us. Rwanda has a very large population that's in refugee camps. So ABEC and the Ugandan nonprofits will transfer those patients as well to Uganda. So anyway, so our preliminary mission in 2019, it was an initial experience. Only the core team went. We closed one patient with exstrophy, did one epispadias repair, assessed their nursing capacities, worked with Dr. Satuma in the OR. That's me operating with Dr. Satuma, started the process of teaching skills. We planned for the next mission to be in October 2020. Of course, we recruited all of our team members. We planned for our exstrophy symposium, and then there was COVID. And as you all know, with COVID, nothing happened. We had to cancel our mission. 2021, still COVID. Plans scrapped again, even though we had made all this preliminary setup. So then we started to gear up for 2022. It was going to be a large initial mission, increased numbers of closures, epispadias repairs. We wanted to follow some of the children that had surgery in India. We did have more commitment from members. And then there was Ebola. And so we canceled again. And then we wound up having a really hard thing, which was Dr. Satuma passed away. So the person that we were training to take over died. He developed leukemia and died. And so you can see it was just hit after hit after hit. So then we started pre-planning for the next year. All of our team members used their own resources to travel. The core team met via Zoom every month. The composition of the team was agreed to. Once the entire team was determined, we communicated every month to keep them up to speed. Patients were identified both by us and by Eurocare. All the potential patients were screened. We got local facilities for the patients and families to come. So in February, we finally did our large team experience. My wife went with us. She's a pediatrician, so she was able to assist. We also took our own scrub techs. Dr. Gerhardt, who was my mentor at Hopkins, was going to join us, but was unable to because he had a family emergency at the last minute. Dr. Paul Sponseller, the person who developed the sponsellar osteotomies, did go with us, as did Deb Schwengel, who's one of our pediatric anesthesiologists at Hopkins. And so we also took patient care advocates. Pam Artigas' daughter actually has exstrophy. She was closed in this country, had reconstruction, so it was really good for the kids over there to see somebody who was an adult, almost an adult now, who was managing a catheterizable channel, had exstrophy, could talk to the kids, play with them, etc. And the other individuals also permitted play therapy with the kids, really trying to develop that sense of family that we have in this country. It was a teaching mission. We provided multiple presentations. Teaching resources that were created by the nursing staff were essentially given to their nursing staff. Dr. Sponseller worked with 2 local orthopedic surgeons, teaching them osteotomies. Dr. Schwengel worked with the local anesthesia providers on pain management as well. All of our presentations that we did were all published in the African Journal of Urology so that they had a resource that they could continue. All of the children were assessed by the surgical team. So our surgical experience, we had 5 children that had initial closure. 4 was successful. 1 had a partial bladder prolapse, 2 epispadias repairs, 1 adult patient who had not been closed. We did a cystectomy and an ileal conduit. 7 patients had follow-up cystoscopy for evaluation of their bladder capacities. So again, the community that we're able to develop, the children able to play, have fun. Our after-mission recap from that very first mission, despite all of the good intentions, Eurocare was not really developed as a pediatric facility. And so the nursing care was really challenged. And we did a lot of closures. We did more closures in Uganda in 1 week than many institutions in this country would do for a year. And so it really, really tested their nursing skills. They did not have IV pumps. They did not have any way to provide that sort of access. Only a single operative theater with access to radiology, inability to really manage postoperative pain control, transfer of nursing care was very difficult. So we then had to really start to change what we thought how to do this. We were unable to guarantee long-term access to care because Eurocare is privately funded. There were no pediatric surgeons anymore with Dr. Satuma passing. And bladder exstrophy management is challenging. Even in this country, it's challenging. So what did we do? Well, we decided that we needed to rethink everything. And luckily for us, a new facility opened in Entebbe that year. It's run by Emergency. It's an Italian nonprofit. I know the name says emergency. They don't actually do emergencies. They only do children. And it's a tour. We toured the facility in February of 2023 after we completed our Eurocare mission. We also met again with the staff at Malago to see if that was a viable option. However, given all of the ethical considerations, we wanted to provide care that was the highest quality and that would have long-term nursing support. And it was determined that really the best chance for success was going to be at Emergency. And so we, again, multiple conversations, planned a limited mission for 1 week, smaller team, smaller patient cohort, went through the same steps of mission planning. Staffing oversight from Italy was provided for Emergency, the hospital. The setup is very similar to the US. It's a superb surgical social services. It's well funded. We didn't really need to bring a lot of things. Local orthopedic surgeons who had been trained by Dr. Sponseller actually wound up being able to work with us. We did 2 closures, additional reconstructive surgical procedures, multiple endoscopic procedures, all of which were successful. Just to show you what Emergency hospital looks like, you can see you could walk into this hospital and believe that it is anywhere in the United States. It really is state of the art. It's completely managed by the Italians. And we were able to get very significant efficiencies. The staff were terribly competent. We were able to transfer information to the local staff. They had 2 pediatric trained surgeons already on site. We created an MOU for a long-term, multi-year mission to Entebbe. And so once we determined the mission, we then planned for another mission in October of 2024, 4 pediatric urologists, 3 orthopedic surgeons, pediatric anesthesia, pediatric nursing, all of that. We went through the exact same process of getting set up. And then we started talking about continence options. And I'm going to go over this a little bit more because the last step of management of exstrophy is the most challenging in an under-resourced environment. Why? Augmentation, cystoplasty, and continent diversion, can we do it? Can they do it? Sure. But there's no access to catheters. There's very limited access to ileal conduit supplies. We actually, the patient that we did an ileal conduit on, we were able to provide him with supplies for an entire year. But that is not viable for 50 patients, right? So you need to find resources locally. It's very hard for the Italians to bring supplies like this from Europe because the Ugandan government has been trying to put duties, export taxes on them, which really make it, again, very hard for them to do. We actually went to the villages to see where these patients lived, to see what they could manage, what they could handle, before we made any decisions with regards to who was appropriate for surgical management. We created an entire algorithm for how to manage urinary continence. This is going to be published as well. So what did we accomplish with our next mission? We did 6 closures this time, 3 boys, 3 girls. All were done, 3 were reclosures, 3 were unclosed, all done with osteotomies, 2 with redo osteotomies. Every patient was successful. We did 6 epispadias repairs, 3 patients with second stage after prior closure, 3 patients with complete epispadias having initial surgery. We decided to take a softer approach to management of continence in that we did ileal chimneys, which, yes, they still require supplies, but we were talking yesterday, remember, these patients live in war zones and in areas where, God forbid, the child is out there and damages their AUG. They need to be able to make it to a facility that can actually handle them before they die. And so we were unwilling to take the risk of having a mortality with one of these kids. An ileal chimney is a drainage thing that is incontinent, but it is also less susceptible to potential injury, which is why we went with that resource. It's not ideal, but it also doesn't take away their bladder. So at some future date, if they are financially able and they move to a location that allows them to have resources, then we can convert this, or they can convert it, or they can have the local teams convert it to an augmentation. And so that was the thought process behind it. So that's what we wound up doing. Again, this is the whole social team that came with us. And you can see the families have now expanded. It was like every time we went, there were more and more and more families coming to us from all over that Eastern African area, from Somalia, from Rwanda, from Burundi, from Kenya, from Tanzania. And so we had a little thing for the kids so they could have a Ugandan dance party come, and the kids really enjoyed this. This is actually the way the place the hospital is situated is actually on the shores of Lake Victoria, which is very scenic. It's beautiful. We did have one patient with a redo closure that we took back for a bowel obstruction while we were still there. We didn't lose the closure on that one. One patient with a complete epispadias repair had some bleeding from the glands that required prolonged dressings, but otherwise was successful. We canceled 2 extra closures. One patient had active malaria, which is obviously still a problem in Uganda. One patient, as soon as we put the patient under anesthesia, we wound up realizing that the patient actually had a roundworm infestation, where the patient started to essentially passage very large roundworms. The local population said, oh, that's no big deal. We see that all the time. Well, we don't, and we're definitely not doing an extra closure on a patient with this. So this continues to remain a challenge. We set up patients and they wind up, having to get canceled. What have we learned so far? Well, it is possible to transfer knowledge to an under-resourced environment, but it is challenging. It requires really a paradigm shift in understanding and expectations, not only of us as physicians, but of the families and patients to accept that this is really wonderful. After we did these ileal chimneys, the initial report was, well, gosh darn it, they've got these things. Now, those children are back in school, they're dry. They're able to play sports, they're able to play soccer. We get pictures from them all of the time saying how wonderful their kids are doing now. So now they're on a pathway to potentially become financially solvent over time, granted, but at least they can now participate. It requires staff that have pediatric training. It requires significant resources up front to be successful. You do need local partners for the logistics. Infectious disease remains a significant problem in all of Africa. And you have to be willing to modify management based on your available resources, but also based on understanding of the local population. What do they want? What do they want, right? So our next trip is actually coming up very quickly. We're going the end of August into September. We're moving our future trips to more of a supervisory role. We've trained them. They have done some extra closures now. What our role is going to be as we move forward is to see how did they do. All of these patients are in a database that we follow because we want to make sure that the outcomes that they are getting are going to be similar to the outcomes that we have at Hopkins. Local orthopedics, there are two well-trained physicians now. They've done so many extra closures. These guys have now done osteotomies on more kids with extrophy than many US orthopedic surgeons have, because we've now, we closed 11 patients already, so many of them redos. So these guys have gotten really good at it. Our next mission, we do have, we're going to teach them how to do bladder neck reconstructions. But again, bladder neck reconstructions in the context of having a second outlet of some sort. We do have a covered extrophy and a female epispadias that is set up this time. We have a complex adolescent female with unclosed extrophy who is going to need surgical management. We're going to review all of our patients that have already had surgery done by the Ugandan team. So I'm going to stop there. I wanted to give you a flavor of what it is, the thought process that we went to in creating what we think is going to be a sustainable model. We hope and pray it's going to be a sustainable model. Why are we going in September? Well, we were actually supposed to go next year in February, but they have elections in February of next year, and even the local Ugandan population said, you should not come when we have elections because we don't think it's going to be safe for American teams. This has obviously been compromised to some degree by, and I think future missions to Africa, to India, et cetera, are going to take a hit from all of the reduction in resources that we're providing to USAID. Because a lot of the nonprofits there that were bringing patients in, that were trying to collect local supplies, were all funded by USAID. And I think our going there, they see an American team coming in, they know that we're in this just to help their children. And so that, I know we talk about soft political power. This is really more than soft political power, because these kids are going to go on and say, yeah, I had my surgery done by an American team. I really like the United States. This is where soft power comes in, because you want to change their hearts and minds, not say, this doesn't matter. It matters. So I'll take your questions.
Thank you, Dr. Matthews. That was a great presentation. I've also done some missionary work in Ghana, as we talked about yesterday. One of the challenges, though, is this is a very specific program for extra-feet. What would you do if a family brought in somebody with, needed a circumcision or undescended testes? Because when they hear that, the U.S. team is coming, I'm sure that not just the extra-feet patients show up, it's everybody else. So how did you manage to keep this focused on extra-feet and not pediatric urology in general?
That's a great question, Humphrey. So the way when the American team came there at the very start, we were very definitive that we were only going to manage patients with extra-feet. And it was not really the patients coming with the other issues. It was actually the other pediatric surgeons saying, hey, you're here, right? You're a pediatric urologist, right? So tell me what I would do with this patient or that patient. And we're, obviously we're going to give them our opinion. We have conferences with the pediatric surgeons there. They put up patients that have valves and prune belly and all these other things. And we give them our input on it. We've really resisted operating on those things just because the kids with extra-feet just can't get it anywhere else. And if we take away any of that time that we're there, we have to do one less extra-feet patient. And I have a hard time not taking care of those kids with extrophy, right? Because their local physicians are actually very good pediatric surgeons. They can do an undescended testis. They can do a stroke. They can do a hypospadias repair. So I really want to be able to have them learn extrophy. I really do. So yeah, we restricted it. It's hard. You're sitting there with, and they're like, well, can't you just do this? And it's like, yes, I can, but, here's Dr. John who can actually do this and do it well. So that's who should do it. Yes, sir.
I'm David. I'm on the PUA board. So the amazing work you're doing, really interesting. I was just curious about, these are very complex operations, obviously. What was the plan in place if there was a complication and you guys you were maybe not there, or?
Absolutely. And that is exactly when all the problems occurs, after we leave, right? So we have to almost change their paradigm, right? And like I said, it's a paradigm change for the physicians. In many countries in the world, you guys work as residents. You guys make rounds every day. You guys see these patients every day. In many parts of the world, that is not what happens, right? Most parts of the world, the only people seeing the patient are the nurses. The physicians, yes, they operate, but then they don't make rounds, and they don't present like you guys do. When you make rounds, you have to know everything about the patient. We made the people over there change to being like residents. So even though they're fully trained pediatric surgeons, we said, we want to hear every day from you. You're going to WhatsApp us, and you're going to give us an actual presentation on every patient, just like you were a resident. And they do. They will, because they want to learn, right? And so yeah, it's been that change in paradigm. Because let me tell you, Humphrey knows, if I operated on an extrophy at Hopkins, I didn't go out of town for the next whatever number of weeks, because I saw that patient every single day. That's what you need to do to take care of patients successfully with this degree of complexity. So it's changing their mindset. This is what you need to do. But we also gave all the nurses our WhatsApp numbers. So the nursing staff on the floor could WhatsApp me or Anthony and say, hey, the doctor didn't see this. What do you want us to do? So for the next 6 weeks, we got a lot of WhatsApp calls, yeah. Yes, sir.
Thank you very much for the lecture. So a comment on the discussion that we had last night. So you are a believer of not taking U.S. trainee to train on kids, right?
I am.
Right? Which is, I kind of share the same view with you. But now, since you train the local pediatric urologist, so for your next mission, do you think it's acceptable to take U.S. trainee with you? Of course, they will not operate independently under your supervision or even the local urologist supervision, because it's most probably trainee, they graduate from programs they haven't seen extrophy. Right?
Yeah, and to my point, if you carry that argument further, I'm firmly convinced that some of these disease processes are diminishing in this country, for a variety of reasons, okay? And so the question then is a very similar question to what you guys put to me about robotic surgery, right? The robot breaks, what do? Well, you're gonna bring in another robot. Well, that's not how I would deal with it, but whatever, robotic surgeons are robotic surgeons. The point is, if you're not going to see that disease entity, why do you need to even know it from a surgical perspective? Can you make that logical step? So if you're never, if one of your trainees here, right, is going to go into private practice, never see an extrophy, do they then need to waste their time and resources learning how to take care of an extrophy?
Then the argument to this, then we should not be testing on it.
I fully agree, and if you...
Might beat the question in the oral board while an extra
Perhaps you should put that in a letter to the American Board of Urology. I don't make the questions on the American Board of Urology.
So I'll talk to them.
No, but no. To that point, the logic has extended to the point where the extrophy closure is no longer a required thing, even for pediatric urology fellowships. It's no longer a requirement that you have done an extrophy closure. So it is changing. It is changing, albeit slowly, but it is changing.
So Dr. Matthews, if you take a peds fellow then, so if you had a pediatric urology fellow, and even though extrophy is not a requirement, but they want to be the next Ranjiv Matthews, right?
I don't know why they would want to.
Would you take the fellow to Uganda to do 10 closures, because that's going to really impact their exposure and allow them to carry this mission forward, when you retire, or the next generation, if you will.
So I would take somebody who's fully trained in pediatric urology. So if somebody said, well, you know what, I want to do a similar mission, can I come with you? Totally. And we are having to expand, because you're right, I am a dinosaur, and I've already seen the asteroid in the distance coming. So I know I'm going away. And that's fine. That's the way the world is. But, yes, so we are taking, so Dan Kukarowski, who goes with us, is from California. He's got a significant experience doing OGS, condom diversions, all of that sort of stuff. But he's now also moving into doing closures and stuff. So yes, somebody fully trained, I think that that's not unreasonable. Dan worked with me or Anthony on all of the cases. The downside is that we're spending time training Dan when we could be training another Ugandan surgeon. That's where the rub lies, right? I would rather train 3 more of their surgeons than train 1 more of our surgeons. And that's why we won't let the Italians send they wanted to send their people from Bambino Gesù to come to Uganda to train with us. And we said, no, we're not doing that. The mission is to train Ugandans. That's what we're going to do. That's it. We're not training anybody else.
Hi.
Yes, ma'am.
I'm Geetha, I'm one of the residents. Amazing talk.
Thank you.
Do you guys have more Ugandan surgeons coming, like in future missions to learn, or the ones that are already trained, will they be like going to other areas?
So that's a really good question. So yes, they have, at this institution, they have a training program. I'm actually on the exam committee of something called COSEXA. COSEXA is the African equivalent of the ABU that actually trains their local pediatric surgeons. And they're all pediatric surgeons, they're not actually urologists. So because pediatric surgeons do most of the extrophy in Uganda. So yes, as their trainees come through, we're continuing to interact with them. And we're continuing to train the junior trainees as they come through. So all of the trainees have actually taken their exams through COSEXA, and they're fully accepted pediatric surgeons in Uganda, yes. Yes, ma'am.
Fantastic talk,
Oh,
and
thank you.
I would counter you're not a dinosaur. You have critical skills that our trainees need.
Oh.
I'm Dr. Chesro from Tulane University, and the discussion you guys had last night is one that all residencies are facing. How do we get critical open surgery skills to our trainees in this day and age? And I would love your perspective on not training them to do extrophy, but exposure to correct tissue handling in complex open cases. And as someone who does reconstruction and urogyn, I'm working to get the more junior residents into my service on a one-on-one mentorship model, because even if they never do a transvaginal case, it's a focus on tissue handling, identification of planes, when you have obliteration of the plane, how to navigate that. So if they go in to help their gyn colleagues, they can identify the issue, repair transvaginal bladder injury. So I've shifted the focus from you're going to be able to do a cystocele to you need to know how to do tissue flaps.
Yeah.
You need to know how to handle tissue and understand tissue quality and what can heal and what not. And I don't have an answer, and it is an issue many programs are wrestling with, is exposure to those techniques.
Dr. Chesra, I don't know if you heard the whispers when you asked the question. There were some whispers that came from the back.
Yes, I did.
Do transplants.
We do, and we're maximizing our time on transplant as well, and we don't have your transplant program, but we have a robust one we work with closely, and also we have, because it's New Orleans, our level 1 trauma center provides us with a lot of chance to do open repairs, but it's still.
I trained, as Humphrey knows, with Dr. John Gerhardt, who he would say, well, you know, when the minimally invasive thing came about, he would always say, well, we're just maximally invasive surgeons. Now, that's one way to train. And yes, tissue handling is so critical. I work with my residents all of the time to be able to say, you know, you need to know how to sew. You need to know how to tie a knot. You need to know where to put your stitch in. Because if you can do that, really, you can actually close an extrophy. Okay, yeah, there are some principles that you need to know. But the basis of surgery is still putting in knots, tying them properly, understanding tissue planes. That doesn't require you to do extrophy or to ever do an extrophy. Dr. Jeffs, when he devised the stage reconstruction, would tell us, you know, you're only here for 2 years as a fellow. I am not going to be able to tell you everything in pediatric urology, as Dr. Kropp would attest to. In 2 years, you can't do it, right? But what do? When you're confronted with the problem, you make it into something you can fix, and then you fix that. That's how you do it. But how do you do that? Well, you do that by learning how to put two pieces of tissue together, the correct pieces of tissue, by putting in the stitches right, by tying them down correctly. Yes, that's exactly the same thing. And people always gloss over things. For example, you know, the residents, my residents are a very tortured lot, mostly because they have to deal with me every single day of the week. So you guys should consider yourselves fortunate that you have nice people like Dr. Sindwani to actually work with. That not so with my residents, because, you know, if they don't put a stitch in right, and right is my way, if they don't put it in right, I am going to take it out and put it in for you again and again and again until it is right. And that's not something that I have the residents do. If I put a stitch in and I don't think it's right, I'm going to take it out and do it again, because you only have one opportunity. This child only has one opportunity. They're going to be looking at this for the next 90 years. And they're going to be cursing you every time they look at their penis and go, man, I can't believe that guy did this to me 90 years ago. That's what I have to deal with. You see? So I am very particular. Every incision has to be right. Why? Because the parents only see the surface of the incision. They don't know anything you did on the inside. But make sure that it's right. Make sure you do the right thing. It's so easy to defend doing the right thing. It's really hard to defend when you're not doing the right thing, right? I mean, these are simple principles that people should take into mind. I don't mean to completely blow off your question,
No,
because
that's
that is
100%
exactly
that is
what I'm
100%
trying,
correct
what
answer,
I'm
and
trying,
that's
what I'm
what we
trying
face.
to do, because I don't actually know the answer, so I'm trying to hedge, but yeah, it is challenging, and you know, to residents, I always say, you need to, every single case you do, no matter how small, you need to consider that a final exam. Why? Because the patient and their family think it's a final exam, no matter what you do, because it needs to be right. So go back, check what you do. Make sure that there's no bleeding at the end of the case. Make sure that you've done all the steps correctly, because it is so critical. It's somebody's life you're dealing with. And you might think, oh, circumcision, who cares? But they do care. They do care. Wouldn't you care if it was your circumcision? You would. You would. So do it that way. Just think about how would you decide, and do that. Philosophy is terrible.
Well, just thinking about the long-term plan for, I mean, what an amazing setup you guys have made, Dr. Matthews. Is the goal to try to bring in, because obviously this problem's, you know, rampant throughout Africa. Is the goal to try and bring in other pediatric surgeons from different regions of the country and start growing the program, or is it to make what you guys have done kind of a center of excellence and bring in the patients?
Yeah, we would like to be able to have, you know, this become a center of excellence just because they have resources. The problem is that travel in Africa is very challenged. Travel from literally, you know, it doubles your travel times. And many of these families, all of the families that we work with, have no resources. They literally are, you know, if $20 is their entire year's salary in some cases, so they really don't have any resources. So the next steps, and that's a great segue, we're planning on working with somebody in Ghana, where Humphrey is from, and then we're planning on working with somebody from Cape Town in South Africa, which will cover 3 broad areas of the continent. But that is, again, it's been so draining to do this. You know, I meet with my team every single month for 2 hours at a time. The core team meets to plan for the next meeting. So we take one meeting at a time, one trip at a time. It's more than that is just too much draining on our bandwidth. So,
Thank you
Puneet,
so much.
I'm so sorry to take up more of your time. Oh,
So, token of thanks for Dr. Matthews for coming. So, this is a little
Thank
gift
you.
from the plastic.
oh, thank you so much. Thank you, Puneet. This is so nice.
Absolutely. Picture time. Thank you.
Thanks again.
What a wonderful, inspiring talk,
Thank you,
and
Dr.
goes
Kropp.
with the
Thank you so
real
much.
spirit of what Dr. Kropp always taught us. Tissue handling was the biggest thing we learned on pediatric urology, basic principles of suture handling, basic principles of closure. Everything that Dr. Matthews discussed with us is what the spirit of pediatric urology is. So moving on, we have a wonderful speaker, Dr. Alexis Chesro. Dr. Chesro comes from Tulane. She trained at University of Illinois, Chicago, and did her fellowship in female pelvic and reconstructive surgery, neurourology, and avoiding dysfunction at Cedars-Sinai. After doing that, she was faculty for nearly 10 years in Milwaukee, Wisconsin. Today, she comes from Tulane. There was some flight delays and some cancellations, but we are so glad Dr. Chesro has made it here. Despite reaching hotel at 3:30 a.m., she is fresh and energetic, and she's going to share her knowledge with us. Welcome, Dr. Chesro.
Pleasure. Thank you for having me. So that's going to be a tough lecture to follow. So
I'm Dr. Chesro. I am at Tulane University. I'm their director of female health. So I do traditional urogyn, but also my first love in urology was actually complex voiding dysfunction, neurourology, and I save a portion of my practice for the complex pelvises, post-radiation pelvises. How's that? Is that better? Perfect. So post-radiation pelvises are post-cancer patients, and I work closely with the transplant team, and I do male and female neurourology. What we're going to discuss today, though, is a little more germane to the graduating residents who go into private practice, and it's going to be APP utilization. And I give this lecture a lot, and it's really, as we discuss APPs, I want you to realize I could give this lecture in the same format about partners, about MAs, about nurses. It's really an introduction as you go into private practice about resource utilization and team building and healthcare service lines. And as we talk about, it's not about the extra fee, it's about tissue handling and building those skills. Building a healthcare service line when you go into private practice is critically important. Let's get started. Yeah. Okay. Is that a better volume? Very good. Okay. So I've been in practice for a long time, and I've worked in 3 main systems. I started out in an employed multi-hospital system with a large urology group practice. We were an integrated EMR. All of the physicians were employed. We could collaborate. We had transplant. So while I was private practice, I was perhaps more academic than a lot of academic institutions. I built their clinical research program, and we established the care of the female patient in the complex pelvis across a 5-hospital system. We had a dedicated women's hospital with a multidisciplinary pelvic floor center that incorporated gyn, urogyn, colorectal, urology, urogyn, GI, pain psych, addiction psych, and as well as pelvic floor physical therapy. So we had a bimodal APP utilization for both hospital and subspecialty support. And the reason I was able to build such different service lines was because I built resource utilization into my practice. I was also in a venture capital owned practice, and they had independent APPs that were completely separate from my service line. And now I'm in an academic practice where I am building a hybrid utilization model for Tulane Urology's first APP that now onboards this fall. Wish me luck. So we're going to discuss a little bit about the background of why this is so critically important. There is a physician shortage. We have an aging population coupled with increased demand for healthcare services. And the AMA predicts there's about 125,000 of us that are just not going to exist by 2034 that are needed. It is even more critical for urology, which we all know. We have one of the oldest physician workforces. Nearly 30% of us are 65 or older. 40% will reach retirement in the next decade. I'm trying to avoid that. None of us want to retire. We all just want to work smarter. That's the secret of urology. Unless we continue to increase urology residency spots, which we're all working on, there's going to be decline in practicing urology numbers until at least 2060. They don't predict our numbers will stabilize for quite some time. So we're going to be facing an increasing burden of care. And there's only 3.8 urologists per 100,000 patients, and 60% of US counties have no urologist. Now that statistic's a little skewed. People travel for urology care, and we need to belong in centers. We're not primary care. We're not going to be in every county, but it shows that we are a critical resource in the healthcare system. So you're going to need an APP. Physician burnout, a hot topic. High patient volumes, lack of autonomy, administrative overload, and the moral distress from navigating complex healthcare systems, which, when I say your first 3 years are in practice, are a true education after you get out of residency. And the burden of electronic medical record documentation, both inbox and charting. Now,
the best way to describe burnout that I've found, it's not one thing, it's the patient care to other work ratio. We are all very good at patient care. That's why we went into this, we love it, we have the skills. It's when the amount of other work becomes so burdensome, it impinges on both your quality of life and ability to provide care at an appropriate level. So as I discuss this lecture, it is about resource utilization to take care of that other work ratio. We all love taking care of patients. The other work is what is going to increase in our medical practice. So if you have 10 things that need to be done, you have time for 7 of them, you're going to have to figure out the other 3. You're going to need an APP. So what is specific, though, to urology burnout? What is happening to our colleagues? So we are both full-time medicine practice, a full-time surgical practice, coupled with a high in-office procedural volumes. You'll hear the statistic a lot, that's why urologists burn out. I'll counter that and say that's why urology is fun and why we go into it and why we love it. Don't listen to them when they tell you that's the problem. It's the other work. We love what we do. I love what I do. And this is why you can go into private practice and tailor your career to what you love. We're one of the few subspecialties where you can do general practice. You could go in and suddenly decide that you didn't realize you love stones, that you love BPH, that you wanted to add HOLIP to your skill set. This diversity of care we offer is our strength. Don't let them tell you it is a weakness. It is not. But we are an end specialty, and I want you to pay attention to that term. When they reach us, they stay with us. We create a population of patients with complex longitudinal care, and we don't let them go. So our patients have increasing comorbidities, but they often still need surgical intervention. Those are our skill sets that we love using. Focus on that other work, and don't focus on the joy of urology being an issue, because it's not. So urology has a burnout rate of up to 54%. We are constantly #1 in burnout, and even the AUA had it rated as 38%, and that is not because of our specialty. It is because of that other work. Urology is delightful. Trust us. So again, 10 things that need to be done. You have time for 7 of them. My residents may disagree because I do chain them to the complex voiding dysfunction, and they have to be able to do video urodynamics. And you learn urogyne, but you will never be bad at BPH by the time I'm done with you. So we're going to go over some basics about why physicians have resisted utilizing APPs. And I'm going to take a moment before I get into it and discuss healthcare teams. APPs have somehow fallen out of the team-based model. When we go in the OR, we're perfectly comfortable with an anesthesia team, our surgical tech, our surgical assist, our nurse circulator. We love them. We know when we go in and we have our favorites, our cases go better. We're very comfortable with that team-based hierarchy in our training and our residents. Your co-residents are your team. And when you go out, you will call them all the time nationwide and discuss cases. That never ends. But for some reason, we drop the ball, not always, on integrating our physician extenders into our team-based approach. And I love your model and how you showed your APP. I have the same model. So what is a nurse practitioner? Traditionally, it was a very skilled nurse who went back and got a graduate level education that allowed them to do more independent practice. They have complex licensing, they have continuing medical education, and they have to research just like we do. Traditional programs, they were an RN with extensive clinical experience first. Now, due to the shortage of care, there's some direct entry programs, and they don't have to have prior RN experience. That's where there's a little bit of controversy. And I equate that back to how we used to be able to have general practitioners. You could do a 1-year internship and then go into practice. Or if you burned out in other specialties, you could be non-board certified and go into the emergency room. We know lack of training leads to burnout. And a lot of the reasons we're having issues with nurse practitioners is their direct entry programs, and they're not given the training they need to succeed. It's inappropriate resource utilization, making them see the wrong complexity of patients. All right, it's not nurse practitioners at whole. Physician assistants were a little different. That's a master's level education, and they were always designed to be physician extenders. Now those two things have been kind of, the distinction between them has kind of gone away, and you can utilize them as you see fit. There's some state differences that at some point for the graduating residents, if you're curious, reach out. Once I lecture for you, you're adopted, you get cell phone privileges. I really don't mind. There's really nothing, I've built multiple programs. Please reach out. Okay, so the controversy was differences in training, especially related to independent practice, clinical autonomy, scope of practice, concerns for patient safety, and fears of role replacement. And none of these are unique to APPs. Physicians have had these problems with other specialties for years. Think of that as more human nature and our inability to integrate them into a team-based service line. We used to worry about IR taking over all our surgery roles. Remember that? We love our IR guys now. We would never think of them as competition. They're part of a critical team. I tell my residents not to take any job where there isn't a robust IR program, but that was a real concern in general surgery, that these IR guys are going to take all my business. GI and colorectal both do colonoscopies. Insurance companies are more restrictive of our clinical autonomy and our scope of practice than APPs are. So for better or for worse, sometimes we do poorly address safety concerns in our field as a whole with other physicians, just as we poorly address them in APP utilization. So physicians are often not the best at team building when we're trying to integrate APPs, but we have so many great team-based resource utilization examples in surgery. You just have to realize you already know how to do this. Okay. So I want you to reformat the APP controversy to healthcare team building. And we know that appropriate utilization increases patient safety, increases quality of care. Post-operative complications fell by 17%, 90-day readmissions gone down, hospital length of stay is reduced, and improved patient-staff communication. So it's improved care coordination, not competition, just like we do in the OR and just like you do with a residency hierarchy. So now we're going to get into the nuts and bolts of, especially I tailored this more for your residents who are going to private practice. How do you talk to administration about the need for additional resources? So every time I say APP, you're going to think resource utilization. So you are sitting down in your private practice and saying, I need an APP. And they're going to be like, who's going to pay for it? So there's different compensation models, but an APP is the only staff member other than physicians that pays for themselves. And your general goal is to cover their costs versus turn a profit. Do you just need your APP to help you out and they just have to cover their salary? Or are you in a system like I was in venture capital where they wanted a profit-based model? And you have to understand the system you're in so you can speak their language to get the resources you need. Productivity considerations. Do you want a dual focus of a well-run APP clinic versus increased physician productivity? I added 3,000 RVUs to my practice by adding an APP. Scope of practice. Understand what the rate-limiting step is in your service line, and that will tell you what you need an APP to do. I'm a urogynecologist. I have to see 10 times more patients to generate a surgery than my general urology colleagues. I need to have volume, and I have longitudinal care needs. So that's my pain point. And my patients call me a lot. That's another pain point. So my inbox hurts. And so you have to know yourself in your scope of practice and decide, of those 10 things, which 3 are the pain point that limit me from getting my work done, providing an excellent level of care, and using my expertise as efficiently as possible. And then turn them over in a profitable fashion. Okay, so how do we get our APPs paid for? And there's several salary models. And there's a base salary model. This is all for stability for new graduates, common in academic studies. That's what I'm working on. Provides predictable income regardless of patient volume. But you have to be careful. As I see more and more patients, it doesn't allow growth of scope and revenue and reward. So there's an RVU-based compensation. This ties directly to productivity for your APP, encourages efficiency and autonomy, may disadvantage some APPs with limited billing opportunities such as post-op, so there's ways to get around that. And if you need them to improve your efficiency, it's really not fair to put them on a direct compensation model if you have them in your clinic doing non-RVU generating work. There's a hybrid bonus model that combines a base salary with performance incentives, and this can be tailored to team-based goals, balances stability with motivation. But you have to make sure the bonuses are reachable, fair, and realistic, okay? The most effective model aligns your APP incentives with clinic and service line goals without penalizing them for non-RVU generating tasks. And that means if you need your APP to work your inbox so you can do research time, you have to find a way they're compensated for what we call the invisible work of medicine. And your administration is only going to look at the RVU generation because those are numbers they can pull up in meetings. That other work is invisible, and we often do it after hours, at home, and other times. But it prevents you from doing the more complex service line build that you need to do. So don't be afraid to address the invisible work of medicine when you're looking and navigating this. And then if that's taken off your plate, you will go back and show, I built a neurourology program. I now coordinate the transplant and neuroservice service line. Because I have other tasks taking off my plate, I can generate these healthcare systems. Okay, so productivity metrics. So this is kind of a general goal. Optimal daily load is about 15 to 20% patients per day, leaves room for emergent visits, same-day courtesy consultations and walks-in, leaves time for them to get their phone call and charting done, 60 to 100 patients per week, taken off your schedule. These are your follow-ups. These are your frequent UTI patients. These are phone calls that actually turn into a walk-in visit. Your nurse can just say, come in, the APP will see you today. Instead of spending 2 hours on the phone, the patient just comes in. It is a huge patient satisfaction model. Physician productivity. Optimize physician effective volume. What's the effective volume? Effective volume is physicians seeing the acuity that warrants our expertise. I'm a very expensive way to get your first mirabegron prescription. Really. Now, if you've had both brachytherapy and external beam radiation, I am the appropriate way to get your first mirabegron prescription. So that type of service line utilization truly lets us use the skills we've developed for the appropriate patient. So I can't emphasize enough a realistic look at service line and operational pain points about what patients need to see me and what ones I'm a little bit of overkill on as a subspecialist or a general urologist, okay? So the APP sees a lower volume to allow integration into the physician's practice to accomplish other tasks. OR assist and your APPs can bill for a select number of complex cases. So while they're assisting you, they are earning our revenue. Physician inbox, physician clinic, office procedures. Don't be afraid when you hear about, we're all very comfortable with APPs doing urodynamics because I know none of you like to do them. Don't lie to me. I know, I train you into doing them. But we get a little concerned when they do cystos or when they do prostate needle biopsies, and that's okay. That's a comfort zone that we will work on. Same-day add-ons, hospital-based. And I was in a group that did that. Some of my general urology partners loved being in the office, and they were very efficient. They needed coverage for call, inpatient consults, and surgical assist only. Those APPs lived in the hospital. And if you get a correct critical care designation for your nurse practitioners, they can bill for those urology consults, and you do not have to see them. So for Foley placements, the nurse practitioner can go in, evaluate them, set them up, bill a level 4 new consult, and send them to your clinic appropriately, or see them for the trial of void. If there's anything concerning, then we can go see them. So just know there's multiple models. And again, it's an evaluation of the practice you're going into and what you need to take off your plate efficiently. So independent practice states, for those of you going into those, are generally 26 states that allow NPs to have full practice authority. PAs have expanded practice in these states here. This gives you more options, not less, for patient load management in clinics and independent staffing of your inpatient consults. So when you enter a state that says they can practice independently, you have expanded team options. And as you build a team, your APP can do more. So you are not practicing in isolation. This is not competition. Make the pie bigger. Don't divide up the pie. Bring them into your service line. And so if you're in a state where they can practice independently, then I can, when I'm on vacation, my APP can see my patients independently and not have to have one of my partners supervising and, you know, who don't understand the words in my notes. Some of my notes read like ophthalmology notes to my general partners, and they freely admit that. And I always say, if the thought of independent practice APPs worries you, well, I got 2 words for you, artificial intelligence. That's going to be a rough ride. Artificial intelligence is no different than APP utilization, service line optimization, resource utilization. You are going to be the graduating generation that gets to utilize AI in a lovely fashion. We're working on integrating it at Tulane. It's a little rough right now, but it is growing rapidly, and you will have more resources in your chart than any generation practicing has ever had. And I trained with textbooks and no videos, so I am very, very jealous. Okay, So create a service line, not competition. Successful integration is a physician APP team-based approach to the entire practice. Every patient is part of the service line. Every patient gets the same evidence-based options, and referring physicians are sending patients in to be managed by the entire clinical team. My hospital, my referring primary care doctors would call my office and ask if my APP was available and say, hey, before I send this patient over, what part of your protocols can I get started for you? And they would give a blurb, and they'd be like, my APP would be like, hey, why don't you start these medications, and I will see them in 2 weeks. They'd be like, great, thanks for getting them into your service line and into your clinical team. That is a shared approach. My APP was never competition. I will say, though, the reason I was spoiled when I got my first APP, and your department will appreciate that, she was trained by transplant urology and peds urology, so I was a little spoiled when I got her. Speaking of tissue handling skills and ability to manage complex patients, she was bar none. So remember, medicine is a team-based sport. Teach your referring providers to value your team, not just you. Okay? Continuing education is for everyone. Dedicated time to go to various societies, dedicated time to do online education and guidelines, go to meetings together. AUA has an entire certification program for our APPs that is phenomenal. So does OGS in Urogyne. You have a whole checklist of skills that you can work them through. Strive for excellence, and we can all be good at what we do. All right? There's not enough of us. You have to take things off your plate. My APP went to all my conferences with me, and I also sent my MAs, and I paid for this, and my nurses to go to their various societies. They would bring their workbooks back, and we would go through that. Education in your team is never wasted. Okay, so now we're going to go into some actual models, and I do this one first because it gets everyone riled up. This is actually a co-fellow of mine who is a Urogyne practice. So her APP has been with her for 13 years. She's probably one of the highest paid urology APPs in the country. She is fully RVU at 32 per RVU, no matter the insurance, and they pay her to see post-ops, which we don't get paid for. But by taking the non-paid labor off of ours, her post-op complications go down and patient satisfaction goes up. You can see your post-ops more frequently. My post-ops for my complex reconstruction patients came in week 1, week 2, week 3. If I was repairing a fistula, that patient lived in my office with my APP, because all of you know, patients who are on their own and not seen do bad things to your surgeries. So, no incentive, they didn't do incident to billing, she was independent. So the APP did 7,200 RVUs per year, 28 patients a day, 5 days a week, 30 to 40 post-ops a month, and did all the urodynamics for the group. General urologists average 7,000 RVUs a year. She's doing the same volume as your urology colleagues. That allowed her physician to do 9,000 to 11,000 RVUs a year and only working 4 days a week. And she is one of the highest robotic volume surgeons for abdominal sacral colpopexy. She does about 4 a week. And she and her APP still to this day sit in an office and talk about patients. It is a shared patient model. The patients belong to the service line, no matter who they see. So 20 to 25 urodynamics a month, all non-surgical new patients see her, and a high volume surgeon. Now she makes about $300,000 a year. And if you go on the physician forums, there's very strong emotions about a non-physician making that compensation. And what I tell you is, it's not that we shouldn't pay our APPs this, we just need to pay our physicians more. Don't get stuck in that trap. Don't get stuck in the trap of someone having nice things. No, our family practice doctors deserve to be paid more. This APP doesn't deserve to be paid less. All right. This is me. This is when I was in my large urology group practice. My APP allowed me to build a clinical research division for Urogyne across the whole system. I built a neurourology program, and my program incorporated, we had a high spina bifida practice, so I was the urologist in the community who took all of the children who graduated from the PEDS program and gave them a home and a place to live, and as well as the post-radiation program that I built for our complex pelvises. So we had a hybrid bonus model. The bonus was available, but honestly, this is why I say it wasn't attainable, because it was designed for a primary care APP. She would never get the bonus. So I compensated her independently. She only did about 2,200 RVUs a year. That paid her salary. I want you to understand how little patients they need to see independently And she did only 1.5 to 2 clinic days a week solo. She was in my clinic like a resident so I could get in more new patients. And one day OR assist. I got up to 14,000 RVUs with her taking 22,000 RVUs. So together we were doing about 16,000 RVUs as a service line team for the Urogyne, and there is a shortage of Urogyne. I worked 5 days a week, but it allowed me to build my clinical research division and see a more complex acuity of patient rather than the frequent UTIs. So she was my OR first assist. She saw new patients. She assisted in my clinic. And I booked time into her schedule to do all of my inbox and my phone messages. My organization had all labs and messages had to be called back within 24 hours. Nothing can sit in your inbox, and it was a system-wide rule. If I had to do that, I would never see enough patients. So we had time booked in her morning to do that invisible work, and that was built into her compensation model. All right, this is what I'm doing now. This is a new APP integration into our Tulane academic practice. We all want to do more research. We all have multiple research programs and our multiple research things built, but we have expanded the scope. Tulane recently got bought out. We were part of HCA, now we're LCMC. We now have access to multiple more hospitals, and we have an influx of non-specialty patients. And we are not a general urology-based programs. We are all subspecialist and fellowship trained. So we are incorporating both general urologists and APPs, and our goal is to get 1 APP per subspecialist so we can expand our subspecialty and be a referral, continue to be a referral center for the tri-state area. So she's going to be salary-based. She is going to be, and the goal is to increase our access to new patients while getting the non-operative patients off of our schedule. So scope of practice, this is a training model. When you get an APP, they need 6 months to a year to learn urology. So she will be like a resident dedicated to Uro-Onc, Men's Health, and me. She will see new patients in clinic with us, and if that patient's appropriate after we work up the plan, that will become her patient. She will have guided independence for the entirety of the full year. So every patient that's added onto her schedule, she will have seen with one of us first, and there will be a detailed care plan that then she will refer back when she runs out of options. And we will take her to all the societies, and we will integrate her into the AUA APP model. And then the reason is we can go to our LCMC overlords who are paying her salary and say, you are going to get a well-trained, certified urology APP out of this practice who will earn her salary, turn a profit, and increase our volume. And we are going to do a pro forma on that and track the numbers. And every time we meet those goals, they will hire us another one. And that's how you don't say, I don't want to do my inbox, I am burned out. You say, I love urology and I need to expand the scope of my practice. Here's the pro forma I'm going to generate for you. Here's how I'm going to have her earning her salary within 6 weeks with 2 days of independent practice. And here's how I'm going to get you a well-trained APP with 3 days of education with me and my partners, and she will be certified by the AUA. This is a resource we're bringing to your organization who will now be a very productive employee. And we are the first group to get this because we presented this pro forma. And general surgery doesn't have one. We are going to get this, and trust me, all my other surgery divisions are watching us build this program, and then our goal is to expand it. Okay. Burnout mitigation. Remember what I said. It is not the clinical care that burns you out. It is that other work. So the army of one mentality just doesn't work, and it is being replaced by a comprehensive team-based approach. These are our colleagues, and they share the burden and the joy of the practice with us. So embrace that. You're going to leave your residency colleagues behind. You've been with them for 5 or 6 years in my practice, and you won't realize how much of a second brain even your least favorite co-resident was. And I say that on purpose. Truly, you will miss them. The resident you thought you never could miss, you will. That was your second brain, your extra set of hands. Someone who took, and I see you guys laughing back there, the work it took off your plate. You are going to have to build a new team, a new family of healthcare when you go out into your practices. And I want you to know it is doable, but it is challenging. Don't let it intimidate you. Call me if it does. All right? So take seriously your responsibility to advocate for your APP's quality of practice. This is their job in their career too. Strict limitations on scheduling so they can get their work done in working hours. They get paid less. So they should have joy of practice just like we do. This makes what we do fun. Really focus on why we do this and why we love it, and utilize your resources appropriately. Okay? So you want to build a truly integrated service line with your APP, realistic evaluations of the pain points and operational rate limiting steps you need to correct. And I use that language on purpose. You say operations gets you resources. Operational performas show I could see X number of patients a day, I could increase the acuity of care I provide, and I could build an APP service line. That math gets you resources. So, and optimize education, strive for excellence. Good luck. Thank you so much for having me.
What a great practical talk, right? So all of you are going into practice. This is what you're going to face. And we talk about, team approach. So first talk gave you the team approach. And this is the practical aspect of that team approach, how to bring it into practice. Questions?
Yes.
So you mentioned how you came...
Siddharth, if you introduce yourself, which year you are.
You mean to stand?
That'd be nice.
What year are you?
I'm Sid. I'm one of the, soon-to-be PGY2s.
Okay. That's going to be a good year.
Yeah.
Hang in there, buddy. Hang in there.
Thanks, David. So my question was about, you had mentioned pro formas and how you essentially brought the proposal to the administration. I mean, we hear day in and day out how administration fights back, cost cutting.
Oh, 100%, 100%.
So, it's all based on projections. So I'm just curious, what goes into it when you're making projections for, presenting this to administration about data that you might not really have if you're going into a new system?
Math gets around egos. Focus on operations. Focus on service line. So I can see 5 more patients a day and provide a higher level of care. They don't care that I can do a higher level of care. I know I can, but I can see 5 more patients a day. And with 5 more patients a day, I will generate X number of more surgeries. But those patients will get downstream revenue, CT scans, lab utilization, facility fees. Don't discount that. Every time I see more patients, I am the entry point to revenue. I am the only one who generates revenue in the system. So the more, I am the rate limiting step to profits. Once you realize that and utilize that language and that math, and I'm serious, you can reach out. I was part of a very large group, and I do not mind, to discuss your unique private practices your graduating seniors are going in once you see what you have, and we can go through it. But math gets you resources. Results get you resources. So I was around 7,000 to 9,000 reviews when I first started out, and I added an APP, and I went to 11,000 to 14,000, and my APP did 2,200. That is a lot of downstream revenue they made off of me. Millions and millions of dollars of CT scans, lab results, hospital admissions, and care plan. So you provide a valuable service to the community. Go ahead.
So, thank you. Ahmed will tell you that when I got to SIU, we've got APPs now with each of our subspecialties.
Just twist the knife. Twist the knife, it hurts.
Sorry. No, but
we'll get there.
I think pediatrics was the first because even when I was at Hopkins, I had Marlowe, as part of my service line. So I've been doing this for years. And you're exactly right. The way to promote it to them. So we get a lot of aborting dysfunction in children, none of which is going to provide any surgical time. So if I was to spend all my time doing aborting dysfunction, I literally would have no patient slots to do all the other things that actually generate money surgically. And so when you present it to administration along those lines, they are quick to understand. The hospitals over there, and we have somewhat of a unique model in that the 2 hospitals are independent of the medical school. But the hospitals realize, oh my gosh, we want these people to be busy in our ORs because we're paying residents and we're doing all of this. The busier they can be, the better. And so the hospital puts pressure on the medical school to say, yeah, get him an APP so we can get more surgery in the operating room. And that's worked very well for us.
And I agree, and I'm one of the rare people who does her own urodynamics. That is an incredibly resource-poor use of my time, but an incredibly great service to my patients. And then I just drag my residents in and torture them with me. But that means I had to be, as a urogyn, incredibly efficient. So me generating 11,000 to 14,000 RVUs one day a week, every week, was urodynamics and not patient care and not surgery. So the rest of my time had to be very, very optimized for me to keep those numbers up. So, but when you go into a system, you have to look at what you need to provide. Every system is unique. So my model may not translate to another one, and that's why I'm customizing the model for Tulane. And I am customizing it for the first APP because I have to show profitability. But once I get them comfortable with that model, I can shift focus and truly use them. So realize there's steps in this process. And as you get more comfortable in your organization, you'll start to realize understanding how administration works truly helps you ask the right questions and get the right resources.
Hi, I'm Amisha. I'm a fourth year medical student. My urology is here. This is a great talk. I was wondering, as far as the profit-based models, since it takes them like 6 to 12 months to actually have the adequate training for your APPs, how long did it take for them to actually start making a profit?
So I am making sure she shows a profit pretty quickly. That's a great question. So it's called incident to billing, where if you see a patient and you write a detailed plan, and one of the parts of private practice going in is, unlike residency clinic, not that you would ever do this, you see the patient and kind of kick the can down the road and hope that the next person on service figures it out, especially with voiding dysfunction. You have to write a multi-step plan. This is your patient. Your note tells you what to do at the next visit. So if you see a complex patient, you're going to write multiple steps in. So the next time you see that patient, you only need to spend 10 minutes really, because if this, if this happens, do this. Because you've thought about it once, document it, and then if you get in the habit of doing a plan for your next 3 visits, your APP can follow them. And that is incident to billing, where they get a higher rate. So when our APP is in clinic with us, every new patient that she sees, so she will see new patients like a resident in our clinic, so we can add more new patients to our schedule. If it is appropriate, I will build a teaching care plan with her, and that patient will go on her 2 days of independent practice. And I have to be cognizant, in my system, we are 50% Medicaid. It is Louisiana. There's no way around that. We have to see a higher volume for profitability. But I know with 2 days of private practice in 6 months, I will have her making the majority of her salary, and then I will pull in that they are tracking our patient access. So I will show increased patient access for 3 subspecialists that they want to grow the programs on, and that she will nearly be covering her salary in 6 months. And then eventually, when we show that, we can add another APP. And then don't forget to play to everyone on your team's strength. My APP hated urodynamics. She would threaten to quit me all the time. I love doing them on my own. So I got the privilege of being able to do my complex voiding dysfunction, and she would run a private clinic that day. If you have an APP who's brilliant at something, play to their strengths. We should all play to our strengths. And that really makes your team efficient as well. So as I work with this APP, we'll see what her strengths are, what her loves are. If she loves men's health, that's where she's going. She can do our injection training in our testosterone patients. Fantastic. She will make a ton of RVs doing that. Those are actually very good insured patients. And so if she loves that, we'll get lucky and we'll get her profitable very quick and have a great example. If she loves women's health, welcome aboard. So.
I'm Roland, we met.
Yes, thanks for the ride.
Yeah. Yeah, very great presentation, very practical. And I have a couple of questions actually. So first one is, how does liability work when you work with?
They're insured, so it depends. So you just get them insurance. And so great question. If you're an independent practice state and they're technically independent practice, they have their own liability. They're shockingly hard to sue because they just don't have the resources. So most places settle and the malpractice is much, much cheaper. So that's why I say people get upset about independent practice. It's actually cheaper malpractice, and you're not liable because they're independent practice. Now, I train them, but in a supervision model, then it's my liability. And that's why I do a team-based approach and a shared brain and shared education. I say, don't worry about being sued, worry about providing good care. Patients, you could be and I love this quote, you could be the loveliest peach in the world and somebody just hates peaches. So I just had to walk one of my residents through a patient who hated what the hospitalist did, but remembered his name and called legal and said she was going to take him down. So, and I sat down with him, and this is what I tell my residents. Take your ego out of it. Like I said, math makes good choices. Good care is always a good choice. So we called the upset patient, she hung up on us, but we offered, come to the emergency room, we'll take care of you. We'll order some labs for you today. We will get you in as a walk-in tomorrow. We see you have a visit scheduled with a competing urologist. They will take excellent care of you. Can we transfer records? Offered all this to the patient, and we remain available for that care. So don't worry about liability. Provide good care. Document your good care. And document efficiently without emotion and ego, and you will be fine. I put in mesh, and I was a referral center for the mesh controversy, and I just documented and took very good care of my patients, and I managed to escape the lawsuits, but I did defend a lot of my patients who had bad mesh. And I say, if you provide good care, I had a patient of mine sue everyone in the hospital, and the lawsuit says the entire system except Dr. Chesro. Take ownership of your patients. Let your team take ownership of your patients. Provide a home for our complex patients that have nowhere else to go because we're an end specialty, and then don't worry about it.
And my second question is, so I think like for APPs, there might be like a high variation.
Yeah,
like
very.
Competency. I mean, not everyone's an amazing NP like Jordan here.
Okay, don't worry.
All
right, it is unfair to ask an APP to be competent unless you put the same pressure on your intern. They are interns. Think about it. APPs come out like a medical student or the old general practitioner. We have unrealistic expectations of competency, but we're so desperate for physicians. Our direct entry nurse practitioners are being put in untenable situations where they get this lovely career-changing, life-changing degree that will support them and their family and bring them into medicine, and then we throw them out and say good luck. They should have supervision, they should have residencies, they should have supervision hours, and we just didn't lobby for it because sometimes managing physicians is like herding cats. It's human nature, don't let it bother you. And education fixes all that. So my preferred APP, other than the one who is trained by transplant and peds and who still holds a special place in my heart, is someone who doesn't have urology experience. Because then they can become my second brain. They can hear my voice in their head. And I practice a very unique specialty, and not just urogyne, but complex voiding dysfunction. So I want them to think like I do. And I want to educate them enough, and that was my rule with my APPs. I want them to go to conferences and come back with questions and challenge my care. That's when I've educated enough, when they're like, are you sure you should still be doing that? And I'm like, well, that hurts a little, but nicely done. So, really, my favorite one is APPs trained in the ER or in GI, or some procedural skills. ICU is phenomenal. They're great. So someone who was invested in their other specialty and achieved excellence in it will achieve excellence in whatever they do. Go for personality and their ethos, not their background.
A couple questions. So if you have your patients...
Introduce yourself.
Oh, sorry, I'm Steven, one of the urology residents as well.
What year are you?
I'm a third year, turning into 4. And I was just wondering, for your patients that you're having them see as post-ops, they're covered under the global.
Yeah, it's a free visit.
But if the APP is seeing them and then you're giving them RVU value, do you set your own RVU value? Or if you had the APP do like your message box, do you give them like 0.05 RVUs for each staff putting message?
Very good question.
Set up those things?
That is going to be based on your organization. So the APP who's getting RVU value for post-ops is because there was such a benefit to improving post-op care and reducing post-op admissions that you don't understand how better your patients do if they can have a little more post-op care. Patients remember 10% of what you tell them, if you're lucky. Really, they do. You write it down, they don't read it. So having them come in, or even just getting a phone call, hey, you went home from the hospital yesterday. We know you didn't read anything. How's it going? Remember, Dr. Chesler told you not to do this. Oh my God, are you mowing your lawn? Please stop. That type of consistent care, patients do better. And that is what I call the non-billable work that improves your outcomes and is important to me. And I just have to find a way to make the math work for the system. So usually the way you do it is say, if I don't see my own post-ops, I can add another new patient. And that's a very easy math. For that particular one, it's a very well-run group in Boise, Idaho. So they are hiring. If you like to ski, go there. And they really take care of that APP because she is a machine and has been with them for 13 years, and she has earned every right. She generates 7,000 RVUs a year, and she takes excellent care of everyone's post-ops. They understand the value, but as a group, they lobby for her. And that's why you treat everyone well, lobby for them. It's their career. So they aggressively lobbied for her career, but that is a little unique. So I had my APP on a salary model because she was employed. I got no credit for her work. But I, in my contract, put that she would be profitable enough to make her salary, but her main goal was to improve my efficiency. And I demonstrated that on both sides.
My other question was, is that, I mean, money only goes so far in terms of trying to keep your APPs, particularly what you like Jordan. But then at the end of the day,
I'm Jordan.
What are other ways that you can try?
You should do what makes Jordan happy. No, really. Whatever you love, however direction, it is your career. And you're not here to make us happy, you're here to be excellent at what you do. And if you do that, everything else fixes itself. But go ahead. Turnover rate is eventually you will need your career to grow. Now, or you will want to do new things. So you have to have a realistic thought of what do you want your career to look like for the next 5 years? What skills do you want to add? And honestly, that's where it comes into. Do you want to do cystoscopies? Do you want to do prostate needle biopsies? Do you want to do urodynamics? Do you want to learn to do bulk emit in the office? You have a career we need to develop, and there are enough patients out there. Don't get sticking points on scheduling and patients. I say, don't divide up the pie, make the pie bigger. There's so many patients who need care. Career optimization, career growth, education, all those issues go away. Turnover is a problem. My APP actually left clinical medicine, but she wanted to start a family. And so she works with a company and teaches physicians. She's the physician liaison. She's fantastic at it. Celebrate that. She should be able to develop her career independent of my practice's needs. And then I train someone else. And hopefully if I do a good enough job, she'll either stay with me forever or she'll go on to another fantastic career opportunity and use the education I get her to get a job she loves. We can't keep you as residents forever, even though it would make it easier.
This is fantastic talk. So some of this before with you. The problem in the healthcare that I have been experiencing is we are always understaffed.
Oh, yeah.
MAs are the first line and they are always low, and then it ends up that the nurse practitioner will be doing some of the MA work and I'm doing some of the MA work. And when you go to administration, they always resist that kind of growth. And the other thing is they don't see all of these tasks that you're doing that's not paid for. And when you are like giving them a performa or any of the discussions, they don't see that math that you're talking about. So how you convince them that this is the math you're going to be seeing whenever we have it? Because it's always going to be something like speculations in the future that you're going to have this improvement.
I've done it a couple ways. When I was young in my career, the statement, if you want to go fast, go alone. If you want to go far, go together. So I built my practice to such a huge volume that it was literally collapsing on itself. And my organization had no choice but to give me more help. And I had another job offer in hand. And I said, I either get an APP or I'm leaving you. And my practice supports X number of patients and you have no one else to give them to. I got an APP. And she was mine and it was in my contract and my partners couldn't utilize her so that I could build my service line. But early on, it is not always pretty. And that's why I say I don't joke that you can reach out about dealing with administration. It is a whole nother skill set that you don't realize you're going to have to learn to do what you love. And that is where burnout comes in, doing things you're not trained to do. So dealing with administration is like doing a surgery that you've never done before, and you're standing there going, I have skills, but they're not applicable to this situation. Oh my goodness, this is stressful. So what he's talking about with MAs, and that's why I say I can give this talk using MAs, nurses, anything. We don't pay MAs enough. There's no way around it. They make more working at Target, an MA degree, and then they go to Target and they get discounts on groceries and clothes. Really, you have to value your MAs. They are the lifeblood of any practice, and there's an MA shortage. Tulane is opening up a nursing school to compensate for nursing losses. We currently have done a pro forma where there's 3 of us, Uro-Onc, Men's Health, and Uro-Gyn, who have capped our practices until they get us another MA, because we don't want our MA that we're sharing to leave. And we have written that letter, and she is a fantastic employee. And we say, I cannot increase my practice to 25 patients a day until you get her a consistent float or hire another MA, and they open the spot. But all 3 of us capped our practices. We're like,
That's what we should need to do.
but it's not great, but it was realistic. We just don't have anyone. And we've actually optimized telehealth to utilize our staffing issues. So we do a couple telehealths a month so that on the day I'm doing telehealth, they can utilize our phenomenal MA who makes everything perfect. She does the work of 3 people, but she shouldn't have to. So we have done everything we can to support her as a valued team member, including telehealth and writing letters and capping our practices. Because if we lose her, they can always get you someone worse. So if you have a valued team member, really go to the mat for them.
And this is another problem, because you value your team member, but the administration don't know how valuable they are to you.
No, they think we're
And for them
interchangeable.
it's very easy. And one of my previous work, it's actually, I had a very nice nurse, excellent nurse. Her daughter had a graduation, and she went to the administration to tell them I need to have the afternoon off, and they told her no. It's like, I'm going to leave. Kick her out. And who was paying the price? I was paying the price.
Yep.
This is why I left one of these places.
Yep, and it seems ironic that you would get an APP before you have MAs, but you almost have to make your practice top-heavy enough. If you bring, when I say physician assistants and APPs are the only ones who generate revenue like we do. So if they won't get you an MA and you get an APP, you kind of struggle for a bit, but then all of a sudden the increased volume meets whatever criteria they have on the admin side to hire open up another MA position. So that's why I am hiring an APP. She is starting in September. We don't have an MA to room. We have a new chairman coming in, and we don't have an MA to room for him. I might show up and do it until we get busy enough. But you have to, once we generate those numbers, then those MA spots will open up. So the problem is it becomes a self-fulfilling prophecy. If we cap, then we don't meet the criteria to open up another MA spot. And you have to know what that number is, and you have to be savvy and go to the administration and say, what is the volume that generates another APP FTE or an MA FTE or an RN FTE, and then you build it, and then you get it. It's just math. And they have those numbers. You just have to pry it out of them.
I think this is very important whenever we think about urology or medical practice, because it seems that this part is more of the bulk of your work. It's how to organize your work and your team to be efficient and be more productive in a way that you don't create burnout for you and your team.
It's really hard to see very cherished partners who are fantastic urologists decide that they can do more for medicine on the admin side than they can on the clinical. And that is something we should focus on. We shouldn't be losing our colleagues to the admin side to other work because they feel the clinical practice is not sustainable. Every generation wrestles with it with a different flavor. You'll wrestle with yours, but you'll add AI into it as well, which will create a whole new ball of wax. Enjoy it. It's worth it.
Wonderful. Thank you, Dr.
Thank you so much for having me.
This is a little gift, and we are so glad you're here.
Oh, I
so
appreciate
residents got to hear. Thank you.
I really appreciate you having me. Thank you so much.
So briefly, you heard two things which prevent resident burnout, right, and urology burnout. This was one big factor how to prevent physician burnout in urology is to utilize your APPs properly. The first one is also related to what Dr. Matthews taught you, is related to preventing resident burnout, because you go and it reminds you why you became physician in the first place, to help other people. You go over and beyond what you do. And Dr. Equena in our department has done so much of outreach, and it was one of his papers. He looked at how to mitigate resident burnout or physician burnout in urology by going and doing these trips, mission trips, and where you go over and above your call of duty. So two great talks this morning, and the third one is now coming up. That probably will prevent also a physician burnout when you can get kidneys off the shelf. You can order it. It will be delivered to you in Amazon Prime, and you don't have to get up in the middle of the night to do a transplant. So we'll take a 10-minute break, and we'll reconvene for that excellent talk.
Fabulous.
So this is next, right? Tech
Tector?
door? Yeah.
You are so fabulous. You know, I want your office to be right next to mine.
My God, I wish it was.
Don't lie. I get on your last nerve.
No, what?
I know
have
I
I ever
do.
said? I've never said anything.
I always call IT like, who calls more than me? They'll name a. I'm like, I think it's me. They're like, it's not. I think it's me. They're like, no. Pain in the butt.
Is lunch on schedule? Show up already?
Not yet. I'm gonna go as soon as he gets started, and I'm gonna go pull water from the.
That's right. Get your cold
Well,
water
there's so
in there.
many surgeon people here. Surgeon's got boot camp. Somebody else has got boot
I know,
camp.
it's loud.
So I'm gonna pull it on the inside, and then pull that tray in here, and then I'm gonna push it out, even if I gotta keep the water on there. And I asked Andrea, if I run out of water, can I have some of that water that's on the ground, and I'll bring her another one Monday. She's like, sure. Yeah, but she put it in the refrigerator last night.
I know. I saw her at it.
Yeah.
Somebody's gonna be happy about that.
I ran in this morning. I couldn't find her. I caught her on her cell. I caught her on her desk phone. It didn't go through. That door was locked. I'm like, ah! And then the janitor or somebody unlocked the door. I don't know this guy right here. I don't know.
Wish I did.
Came. Oh, hi, Dr. Schroeder. Came in and opened that door. And I was like, the water was already in there. And I was like, thank you.
All right, we're going to get started.
We're ready? Okay. All right.
I'm gonna just turn this on and leave it right here.
Where is he, Dr. Tucker?
All right, we're going to all get seated and get started so we stay on time. Everybody, if you want to get your seats taken. So we're going to continue the innovations part, and you see we talked about the theme of the meeting was how to prevent the burnout and how to help with future of urology in various fields. The biggest part of our discussion, as you know, is managing odd-hour calls. We've been working on this xenotransplantation, how it's going to change the field of renal transplant. It's sooner rather than later, I hope. We've been thinking about this for last 30 years, I think. I had a wonderful dinner with Dr. Tector. He's one of our featured speaker today, and we're going to talk about what are the progress and the things that are going on in the field of renal transplantation or xenotransplantation per se. So Dr. Tector is a general surgeon, transplant surgeon. His father himself was a cardiothoracic transplant surgeon. He trained at IU, and after that, currently he is at Miami. He is an independent owner, and he developed the technique with the knockout monkeys and pigs, and now we are looking at these knockout organs that will be transplantable into humans. We had a great discussion last night about what the future might be and how it will change our field. So without much further ado, I think it's a great talk. We are all looking forward to it, how it's going to affect all of us and our patient care in the field of organ failure and organ transplantation. I want you to give a big shout out and applause to Dr. Tector.
Thank you, Dr. Sindani. It's really very nice to be here. Can you hear me? I'm always nervous about these things. I was telling Mike Rees that a bunch of years ago, there's a guy that, he's going to be in my talk, who is from the UK, very smart, and one of the reasons Mike went to Oxford, and Dr. Roy Cullen, and he took this into the restroom. And it was on, and he looks like and he sounds like Austin Powers, okay? And so I never will drop that image, so I'm always nervous about putting these on. I will start by, this is my disclosure slide, so while we're talking about that, I'm going to say I'm thrilled to be here, and it's very exciting to see the program, and I think you can see that this transplant program, which is kind of a dream of at least 3 or 4 people over 30, 40, 50 years, that it's really about to explode, and it's doing great things. And I'm hoping that there's somebody here that's going to hear this talk and listen to it the way I did when I was really young. And that is, so I'm going to dispel a few myths. I don't really believe in talent, and I don't really believe in smart. These are not innate gifts. People are bright enough to use what limited skills they have. And so what I'm going to tell you, everything that I'm going to talk to you about today are things that I learned after I was finished with my training and when I was a wildly, wildly active transplant surgeon. So there's an unlimited amount of things that you can do in this world. And I'm going to tell you, life is very much like a James Bond movie if you let it happen. So, as you know, organ shortage has been the bane of existence of transplant since the beginning of time. And so xenotransplantation has been the long awaited dream that, hey, if we can get organs for everybody, then transplant becomes a really spectacular, spectacular therapy. And so when we're going to talk about xenografts, there's 4 critical elements to success that you have to think about. And so you need the right donor. And so for xenotransplantation, that's going to be the right pig. Then you're going to need to be able to pick the right patient to transplant. That's going to be histocompatibility testing. Then you need an immunosuppressive regimen that you can use that isn't so draconian that it doesn't really take the patient down and make their quality of life terrible. And then you have to pick patients that actually have a chance to do well. So those are going to be the 4 elements we're going to talk about. And so the first thing I want to talk to you a little bit about is, where is xenotransplantation right now? And for the young people, we're always looking for people that are medical students, residents, that want to get good experience. And a lot of people say, oh, I can't do this. But as urologists, you're surgeons. And so even the gene engineering, that's surgery on the smallest level, right? You're cutting 4 base pairs, okay? So DNA technology, it's a language with 4 letters. That's actually pretty simple if you can think about it like that and you can keep it straight. So xenotransplantation right now is, so let's talk about our preclinical transplant. So when we're talking about preclinical xenotransplantation, we're talking about taking a gene-edited pig, taking its kidney, and transplanting it into a rhesus, cynomolgus, or baboon primate. For our experience, we've used rhesus monkeys. They're between 3 and 8 kilos, so they're small. And so what I can tell you, and what's really started kind of the revival, was when we started transplanting relatively simple pigs. So you and I have antibodies that bind to the surface of pig cells. And we have those antibodies because during the course of evolution, we have deleted glycosyltransferases that pigs have not. And so we make antibodies to these sugars. So when you're a baby and you're fed, you colonize your GI tract, and you make antibodies to these. Alpha-gal was the big one. So using very simple, so alpha-gal and with a human decay accelerating factor transgene, or alpha-gal, and then there's a second glycan we deleted, beta-4-gal NT2 transferase. So there's 2 gene knockouts. Okay, so this whole series that we're going to talk about here, we've done over 200 transplants, and we've done them in series. But what I'm going to tell you is, so we did these simple pigs. We then screened them for low levels of the monkeys, low levels of antibodies against the pigs, and then we used immunosuppression. That's not too dissimilar for what you would use in a patient. You do some T-cell depletion, got 1 shot of rituximab, so a little bit of B-cell depletion, and then you use CellCept, steroids, And I'll show you my tacrolimus results. They're disappointing, but we use this co-stimulation blockade. And what you can see is, and so I'm sure there's going to be somebody in here like me, and a lot of transplant surgeons, our great ability is to say, you're supposed to help 100 people, and 90 of them died. With a transplant surgeon and all of you is going to say, let's talk about those 10 people, right? And so you look at these and you say, gosh, look at that. That's 1,600 days, right? So that's really great. But here's your reality that you're dealing with. There's all of these monkeys that are having early problems. So you see it right at about 365 days. We're right at 50%. So half of them are surviving a year. So that's encouraging, and it tells you what you could do. But you have to focus on what your problem is, because you're not going to be able to introduce a therapy where 40, 50% of your patients lose their graft in 3 months. So what I want to tell you that's important is workable immunosuppressive regimens are available that can make this work. Okay, and so when we talk about what that means is you want to use drugs. So every time you're doing something new, you want to have one variable. You don't want to have 20. And so when you're using an immunosuppressive regimen that has a whole bunch of different drugs, here's the question that everybody should be asking. Wow, what does that do to a guy when you give him that? Well, what does this do to a guy? And so the more of those questions you can't answer, the worse you're going to be able to do. So we're trying to keep it as close to allograft as possible. But so here's what we have. So all of these monkeys that we're doing, we're making these organs for humans, they have antibodies. So they're CDC positive, cross-match positive transplants. So it's similar to desensitization in allotransplantation. And so we're going to use T-cell and B-cell depletion for induction. We give an anti-complement agent to cover some of the IgM antibodies. We give that for about 70 days. CellCept, steroids, and then we've replaced tacrolimus with the CD40, CD154 pathway co-stimulation blockade. It's an antibody, and they're in clinical trials, and we'll talk about that. And so this is a regimen where we used a very simple pig, gal knockout with a CD55, and then we gave, so CFZ533 is a drug called iscalimab. I think you guys actually were part of that trial, were you not? You weren't? Okay, but so it failed in trials because of how the trial was designed. It was not the drug that failed. And actually there were arms that did really, really well, and there were arms that did poorly. And unfortunately, a lot of times when they design these drug trials, they let people push them around, the pharma companies. And if you know how the drug works, you would have said, gosh, that arm's going to kill your trial, and it did. But so we gave CD4 depletion for T-cell depletion. We gave CD20. We give an anti-C5 antibody weekly for the first 10 weeks or 70 days, then CellCept, steroids, and this antibody. And so when we did that, we did 6 transplants, and you're going to notice I have 2 right here that went out early, right? It's a little blurry, and I'm sorry for that. But so they went out at 22 and 26 days with normal histology. Now this is my fault, and if you look at this, if I could stop doing dumb things, we would be there. Okay, and so this is what I did that wasn't very smart. So pigs have no immune system when they're born. They have no T cells, no B cells. All they have for their first 2 months is whatever antibodies they absorb from their colostrum from their mother. So they get a lot of viral peritonitis. Not tons and tons of them, but it happens on occasion. So this donor, single donor, had all of these strictures along the, it had a very ectatic ureters from viral peritonitis. And so here's the calculus I did. I was already about $100,000 in with each monkey when you talk about buying them, conditioning them, cross-matching them, doing the drugs. And so I thought, okay, we're going to do this anyway. So here's the problem. At 22 and 26 days, those strictures tightened up. So now if that's a patient, you could take them back to the OR and revise it. The monkeys, you have to put them down. So they went down with no rejection, so they're censored out of the survival. But so the other recipients went 171 days, 315 days, and then 439 and 450 something. So they got past a year. Now that's important because if you do allografts in monkeys, you get about an 80% 1-year survival. Because remember, no monkey wakes up wanting to get a kidney transplant, right? So there's your first starting problem. Then you can't hydrate them whenever you want. You can't make them come inside when it's summertime and they're out running around playing a little bit and they get dehydrated. You can't measure drug levels carefully, and because every time you do that, you have to sedate them a little bit, and then they miss water, they miss meals, and you're talking about 3 to 8 kilo animal. If that animal loses 800 grams to 1.2 kilograms, they make you put them down. So you have to be really, really circumspect. But so that's still very, very encouraging. And if you look, this drug, they wanted it, Novartis had to test it, and the FDA said you can use it in allografts, they had to go 100 days of survival. So we easily meet that, which that's exciting. And you look, the animals had good creatinines until late. You can see these two animals, the 26-day failure, and then you can see, but everybody else, their creatinine was good, their electrolyte management was pretty good, so the kidneys are working okay. So that's exciting. So now, what's the problem? The problem is still antibody-mediated rejection, okay? And survival has a bimodal distribution. And if you can move this curve to that curve, then you're going to be in business as far as doing a trial, getting this through, and getting this as a therapy that can be wildly propagated throughout the world. So when you have early graft failure, you have a lot of parenchymal hemorrhage, thrombotic microangiopathy, you have a lot of IgM if it's really early. And late, you get transplant glomerulopathy, just like you see in allografts later on. And so what I'll tell you, so if I make predictions, be very careful, because the next one I get right is going to be the first one. So I thought that this would be all IgM glycan and that it was no SLA. I was dead wrong. That's not uncommon. And late rejection is likely to be class 2 SLA. That I wasn't quite as bad at. And so you have to fix that. So now you probably heard about the University of Maryland did 2 cardiac xenografts. And those grafts went down at 60 and 40 days. And so this is going to talk to you about the importance of patient selection. Not as much from a medical perspective, but from an immunologic perspective. Who can do well? So they did 2 transplants. So that's Bart Griffith and Mohammed Wahid, 2 very good friends of ours. And so they brought these cases to us afterward, and they said, we did these cross matches, but your lab has been working on histocompatibility for 15 years. Could you take a look and see what you think of our patients from a would you have done them standpoint? And so if you look at this is the case 2. This one had more problems with antibody-mediated rejection. So it started at like day 3 or 4. By day 13, they had to do some pretty serious treatment. There's a lot of IgG, which that's tough. But this patient had a PRA of 0, so not sensitized. Pre-transplant, they used an endothelial cell antigen, and this is where our brains sometimes hurt us, because we think, oh, this makes a lot of sense. This should be right, and it turns out it's not a great way to look at this. But in any event, this looked like it should be an okay case. This is the first guy that they did. This person was also had a CPRA of 0, even with a low-level HLA-DP1 antibody, but again, deemed to be satisfactory. And again, had a lot of problems with antibody-mediated rejection. So I think a lot of the people in the room are too young to remember when we had to go completely on CDC cross-matches, so cellular-dependent cytotoxicity. But when you do those assays, you take lymphocytes from the donor and you incubate it with human serum, and then you put baby rabbit complement on there, and then you look at the percent killing. You would be very comfortable doing a transplant with less than 10% killing. 20% killing, people would still say it was weak, doubtful. I don't think that's right, but that's what we did. But so you would go. Beyond 20%, you were backing out. And so we did just those cross matches. And that's what everybody's relying on in the field right now is 1970s cross-match technology for xenotransplantation, which is the first no-no. We know we need to do better, so we should before we get going. So we did these CDC cross-matches. Now, we've cross-matched over 4,000 patients over the course of the last 10 years. And if you look, about 15%, maybe 20% of people have a cross-match like this, where it's much less than 10%. This is the first Maryland patient. Okay? The CDC cross-match was 35%. That is a very, very positive cross-match that you would never intentionally pick if you knew that. The second patient who had all the antibody problems, That person had a 62% CDC positive cross-match. That is a really, I mean, you would be, you know, if you told Dr. Kropp, hey, the CDC cross-match was 62% and we're going to the OR, he would probably jump in his car and be in your office in a matter of minutes, right? Because that's going to fail on the table. So then the question becomes, okay, so these weren't great cross-matches. What do the antibodies bind to? So like allografts, xenografts are very similar. There are blood group antigens or glycans, and there's MHC. So to look at blood group antigens, we took the same serum and we incubated it with red cells from the triple knockout pigs. Okay? And then if there are any antibodies that bind to the blood group antigens, they'll stick, and then the cross-match will go down when we repeat it. So that's before we absorbed it, that's after. That's the first patient. So that patient has some antibodies against blood group antigens. The second guy had a lot of antibodies against blood group antigens. Okay, so that's going to be a problem. So now the next thing is, at this point in time, we had made these class 2 SLA beads. And so we started looking at SLA at DR. So pigs, you have HLA A, B, and C. Pigs have SLA, swine leukocyte antigen. They have 1, 2, and 3 are the class 1, and then DRDQ, very similar to the HLA. And so if you look, though, very surprisingly, this patient, the first one, had an IgM DR of 150,000, okay? And we've done lots of cross matches and allografts, and I got to be honest with you, this is so high that I didn't believe it. And I made the guys and the people in the lab, and I made Sabrina redo this for months until she finally said, look, how dense are you? This is the answer. And she's right. And then if you look, the other thing that's interesting is before transplant, this person was sensitized, okay? Sensitized with a CPRA 0 to SLA-DR. So that's a problem, right? Then they also had significant DQ antibodies. So that's a very surprising finding. What's interesting for the second person, look at this. So he's up around 200,000 for the DR, okay? But look at the DQ. That's 900,000, okay? We've never, ever seen a level like that, okay? And so, and if you look at the graft, the guy had tons of IgM in his graft early. So that's a problem that we weren't anticipating. So both patients had antibody-mediated rejection causing graft loss within 2 months, and more sophisticated cross-matching can show antibodies that bind against sugars that are on red blood cells and SLA-DRDQ. We didn't have our class 1 beads yet, and we're going to talk about that. But here's the good news. Genetic engineering is able to address that problem, okay? So if somebody is interested and wants to come talk to me about coming and visit us and getting involved, great. But here's what I'll tell you. Surgical research of all specialties is in peril because surgeons are basically have 2 modes right now. They stick their hand out and say, if you have something for me to sew in, I'll do it. Or they're dropping tissue in there and they say, don't forget me when you publish, okay? We have to get more involved in that, okay? So we have to be able to alter this. And that's, so unlike allotransplantation where you're always blocking the immune response or downregulating it, you can totally avoid it with genetic engineering because you just cut out what causes the interaction. And so Dr. Starzl, so I'm sure a lot of people know who he is, but I worked in his lab at the University of Pittsburgh when I was a kid in '88. But he, in 1964, so this is not new information, right? This predates my existence on the earth. And so he says xenograft rejection, including the hypercuvarati, is just an expression of mechanisms that afflict allografts. And so if you can think about it like that, it makes what you need to do very, very straightforward. So what we did with Andrew Adams and with Stuart Connectly is we compared them. And so in xenografts, I told you, all of our monkeys have antibodies. So we compared transplant in a sensitized recipient, an allograft, to a xenograft. And so Stuart has this model where he takes 2 skin grafts and he puts them on, and they change the skin grafts out, and they develop antibodies against each other, and then he does the transplants, and then he's able to evaluate desensitization strategies and immunosuppressive protocols. And if you look at the immunosuppression, they're very similar, right? So He did some desensitization to handle the antibody. We use this anti-C5 antibody to handle the antibody, but otherwise, they did T-cell depletion, steroid, CellCept, and either tacrolimus or this anti-CD154 antibody. And so what's interesting is when you look at the survival, look at this. So the dotted lines are tacrolimus-based immunosuppression, okay? Blue is xeno, red is allo, but that's pretty similar, right? So tacrolimus-based immunosuppression in a positive cross-match isn't very good. And that's why we keep trying to go back to it, but it doesn't work. And that's why when they start doing clinical trials where they're using tacrolimus, that's going to be doomed to fail. But if you look at the CD154, that's also, it's better survival, but it's also very similar to the allograft. And when you look in the allograft, so the grafts function till late, but here's the thing. When they do a T-cell cross-match, it'll give you some kind of idea about class 1 antibodies. As the grafts reject, the recipients make antibodies to class 1. They have MAMU as their MHC, but so it'll be like HLA. And they also make antibodies to class 2 MHC. So that's not a surprise. So that made us say, okay, why don't we focus on the MHC like has been the story for transplant since the beginning of time. And so this is the illustrious Dr. Cowan, unbelievably smart guy, but he's the one who walked in with a microphone to the restroom. But what he said in 1989 was, he was asked what needs to happen for xenografts to work. And you're going to say, gosh, Joe, you're really slow because I'm on step 2. But so if somebody wants to use a pig as a xenograft, you have to turn a discordant, and so basically that's just the degree of species variation, but really means high level of antibody into a concordant reaction, or one with a lot less antibody. And then the second part, he says, is tailoring the MHC in the animal might be a way to downregulate the rejection. And again, so 1964 and 1989, so I'm not working with new information. So when we talk about the swine leukocyte antigen, what's in the pig, pigs have class 1, okay? So unlike humans who have HLA A, B, and C, there's 1, 2, and 3. Everybody blew off 12. We have a paper coming out where we're going to show that's one of the classical molecules that you absolutely are going to have to consider. Then you have HLA E, F, and G. Pigs have SLA 6, 7, and 8. They're numbered this way so that everyone knows that the pig's class 1 molecules, each one of them is more like each other than any other species. They labeled class 2 as DRDQ because SLA-DR is more like HLA-DR than it is like the pig DQ, and DQ has the same route. So they're very, very similar. And just so you know, like when you knock it out, the way to create knockout mice, they knocked out beta-2 microglobulin. And so that gets rid of it because beta-2 microglobulin associates with all the class 1 molecules. The problem with knocking out beta-2 microglobulin is the animals get insulinitis, they get hemochromatosis, and they get a cardiomyopathy, which none of those are good characteristics of a donor. And then the other part is in the kidney, beta-2 microglobulin is important in shuffling antibodies back and forth that get passed through the glomerular barrier. So we engineered it differently, and I'll talk about how we got around that. It wasn't hard. So we made this SLA bead assay. So you know how you have HLA beads. So you have HLA molecules impregnated on polystyrene beads. We did this with Werfen, who used to be, they used to be Immucor. But in any event, so we made these beads. And so we created beads specifically for our pigs. Now, since our pigs are clones, and we'll talk about how we're going to get around that for breeding, every pig is the same. So it's like a mouse strain, right? So we're dealing with one set. It simplifies things for us. So we made SLA1 beads, we made SLA2 beads, 3, DR, DQ, and then we made 6, 7, and 8 would have just recently come, and then we're able to evaluate it on a Luminex binding platform. And so what's interesting is then we went back through our series of animals and we looked at, okay, do the recipients of these xenografts make antibodies against MHC? And people, so I was in a room in the beginning of June at the Mass General where they had all the xenograft efforts in the world talking, and they said, who thinks SLA antibodies are important? And I was the only person to raise my hand. So that's often uncomfortable. But so if you look at very early graft loss, so in the first week to 10 days, that's IgM mediated. okay? And it happens before a class switch occurs. Class switch isn't going to occur any earlier to IgG than 6-7 days. That's the earliest. But you're going to get a lot of thrombotic microangiopathy, some parenchymal hemorrhage. You have a lot of IgM with some complement activation. So this is a monkey that got a GAL knockout, beta-4 GAL knockout, so 2 sugars are gone. We also knocked out SLA class 1, and that'll be interesting in a second because I'll show you why. And IgM was prominent in the glomerulus, right? So look at this. So we looked at the beads, right? And so this is IgG, this is IgM. There were no IgG antibodies against swine leukocyte antigen. And I told you this is a class 1 knockout pig. So it did not form any antibodies against class 1 SLA. So that's reassuring for our assay. But look at this. It had a huge IgM response against, this is an SLA-DR molecule. So SLA-DR, and this is a DQ and that's a DQ, took out this graft, okay? So that's pretty interesting. If you go out a little bit longer, and so this is between days maybe 14 to day 60, IgG starts to be more important. And so you can see here, if you look at this glomerulus, it's kind of swollen. You don't see the fine, capillary, the membranes. And then there's a lot of IgM. There still is some IgM. This is a GAL knockout, beta-4 GAL knockout, so 2 things. It had tacrolimus-based immunosuppression. It went down in 21 days. It had GNM, but look, had a lot of, this is a class 1, this is SLA1, that's SLA1, that's 2 and 3. This is DR, that's DQ, that's DQ. Made a ton of antibodies. And there was also some M, right? So there's a lot of SLA antibodies going on, so they matter. Now, we looked at long survivors. What happens when you get a long survivor? Why don't they go down? So we looked at 2 animals. They're both beta-4 GAL knockouts, so 2 simple sugars, survived 547, 557 days. And so you look and you say, okay, they had good renal function until the end, okay? This is a monkey that we found out was spitting out his cell sept, and so we had to fix that. But model problem. But in any event, if you look, they didn't form antibodies against class 1 or 2, right? And we looked at M, they didn't have it, but because it's so late, you'd look at G. So they didn't have antibodies. So late, if they go a long term, they don't form these antibodies. So anti-SLA antibodies are developed in recipients that have early graft failure, and recipients that survive more than 100, 180 days have very, very few, if any. Okay, and so SLA could be a target for gene editing. And so my lab is basically a fertility clinic for pigs, right? So we engineer these pigs based off it. So we knocked out class 1 SLA. And so the way that we did it, so we didn't get all those problems with the pig, is you have beta-2 microglobulin associates with every molecule. So we just found where beta-2 microglobulin binds, and we knocked out that part. And in doing so, it took out SLA1, it took out 2 and 3, it took out 12, which when we made this slide, we thought it was a pseudogene, and it is not a pseudogene. And then it took out 8 and 7, 6 doesn't really express. So it took out both classical and non-classical, as best we can tell. So we made those. Then we also, so the other piece of this is you want to do this in a scientific fashion so you can actually sort out what's happening. So rather than doing tons of modifications, we kind of go one at a time. So we also knocked out SLA-DR. So we made those pigs. These pigs are not, they're about 18 months old. This slide is the picture. I've been lazy about getting another one. But so DR has 2 chains, alpha and beta. DQ has 2 chains, alpha and beta. So if you get rid of one of the chains, what you don't want to have happen is to have a new molecule form. So if you get rid of, it turned out when we got rid of DR beta, that DR alpha could form with DQ beta and make an entirely new SLA molecule. You don't want that. So for that reason, we deleted the alpha chains. And when you look at the kidneys, there's no DR expression, okay? And I'm not going to go into all that. If somebody's interested, I could bore you for hours with it, and we can talk about it. But and they express DQ normally. We also made DQ pigs, okay? And so like I told you, because DQ beta and DR alpha can form new chains, We knocked out DQ beta in these as opposed to alpha for the DR. And these pigs are bucking right up on 2 years of age, and they had no DQ expression. And so one of the other interesting thing is you, again, don't let your brain prevent you from doing experiments, right? So everybody says, oh, they're going to be immunocompromised and you have problems. And because everybody talks about DQ and allotransplantation right now, not DR, we made this one first. And so, but what we look for is mammalian proof that what we're about to do is okay, right? So GAL, you and I knocked it out. So we're walking around living proof. SEMA, same story. Beta 4 GAL, about 80% of people have knocked it out. So that's mammalian proof. So for DQ, cats have feline leukocyte antigen. And when I mean cats, I mean lions, tigers, bobcats, they all do. Tabby cats. So, but they deleted DQ during the course of evolution. So there's your mammalian proof that things are going to be okay. And that has not led us astray. So we did some transplants with the class 1 knockouts, and what I can tell you is we got good survival in those. Again, these are not hard to make, but it's in an academic center, if you can imagine. I'm cloning pigs in downtown Miami. I mean, I don't think anybody thinks of, hey, where are your pigs? They're on the 8th floor across the street from the hospital in downtown Miami. You know, it's not exact, but so this one went out 205 days, this is 414, but you can see they really didn't make any of these SLA antibodies. So you can get reasonable survival doing that. So now though, when you look, so what I started to ask was, what do you think's more important, DR or DQ? And everybody said DQ. So then I started looking at, okay, how do you handle your people with high levels of DQ antibodies? And everybody had opinions. And then I started saying, well, what do you do with high DR antibodies? And everybody had the same response. You know what, let me call you back. And nobody called me back. So then I started looking at, in our series, there were no people that had high levels of DR antibodies because their graft failed, right? So it's kind of like the World War II story. Where should you reinforce your plane so that it can't get shot down? And they're counting all the bullet holes. And then some guy walks by and says, man, you should look where there are no bullet holes because those planes are in the ocean. And that's right. So DR, so we were creating a survivorship bias that we didn't want. So we're going with DR. So we talked to the FDA about doing a triple knockout, so the 3 key sugars and DR. And so they said, do 4 transplants. If 2 of your monkeys are out, 6 months, you're going to be good to go. And so we hit that. June 16th was our 6-month mark. And so now this again is going to be where you say, oh, wow, you know, he's smart. I'm not smart. In fact, I did very dumb things, and then later on, everybody forgets about how dumb they were, and then good information comes out, and then you look smart. So you just have to be able to capitalize on rough experiences. So one graph went down in the first week, and so I'm sure you can imagine, you're doing 4, you're nervous, they're expensive, and one goes down, you're like, oh my God, am I nuts, am I wrong, is there something I don't get? Then another one went down at day 125 and at 126, and very, very upsetting. But the other ones are still going. They're at about 100 and, what's 94 days now? So we're going to let them keep going until I know for sure the FDA doesn't say, oh, we want you to have those things go a year. But so the first graph went down from IgG-mediated antibody rejection, that's incredibly unusual. The second one went down to IgM-mediated antibody rejection at day 126. That's also incredibly unusual. By that time, that should be G, and we're going to talk about it. But preventing this kind of early graft loss is exactly what we're going to have to do to be able to make this work. And I have great news because failure of these grafts is due to inability to recognize an anti-pig antibody. And that's on me, right? So that's bad selection. So this is our first one, okay? And he went out at 7 days. He's got some thrombotic microangiopathy. Had a lot of cellular infiltration, which that's really unusual in a xenograft at this point. And then, so Chris Burlack, who got his PhD here and is with Mike and has been working with us for a long time, he did all the confocal microscopy, spectacular. And he said to me, God, Joe, I think I screwed up the confocal because there's just IgG everywhere. And I was concerned, but I said, well, let's take a look. So here's all this IgG, and it's diffuse. That is really, really, really unusual. And then there's C4D staining, so there's complement activation. Now we gave a C5 antibody, so the membrane attack complex doesn't get formed. That's why that's negative. But here's what happened. So about a week after we did the transplants, and just as the graph was going down, we got our beads to finally work really well. So we couldn't ask this question when we did the transplant, but we could once we did it. And it turns out, so rhesus monkeys are the preferred model for COVID research. And so before COVID, I used to call the primate center and say, we want to do some transplants. I need to screen a batch. And they'd send me serum for between 1 to 200 monkeys. For this group of four monkeys, and we're going to the FDA to go to the clinic with it, they gave us 5 monkeys to screen. It's not really a screen, right? It's kind of having some kind of weapon put against your temple. So, but in any event, this is because of poor selection. This monkey was highly sensitized, an MFI of over almost 3,000 for two of the DQ alleles, okay? So that's a problem that we could avoid with this cross-match now that we have it. I would never have picked those if I had known that. So that's my fault. The second one went down at day 126, and now at this time it's always IgG, except when it's not, right? And so you can see that there's glomerulopathy. You can see that the glomerulus is totally kind of occluded and swollen, and then there's all this thrombotic microangiopathy. But when you look at so Chris did this is beautiful confocal work. Look at this, all IgM in the glomerulus, and it had a significant amount of IgG. So this recipient had a high level, a really high level of specifically SLA1-1201 donor-specific antibody, okay? And I'm going to show you that level never went down. And again, we did these transplants without doing these cross matches. And so again, that's my fault. That's poor selection. So, but the good news is, and like I told you, if I could stop doing dumb things, this would work. And so this is one more dumb thing I'm not going to do again, right? So we're inching closer. So these are the 4 animals that we did. And so if you look, here's everybody else. This is the first case. These are all their beads, right? So of other class 1. But look at how high. It's 4,000 against the SLA1-1201 molecule. But here's what's interesting. At day 70, we stopped the C5 antibody. The C5 antibody keeps IgM effects at bay. If I had known that this level was present, I wouldn't have chosen it. If I had known at this point that it had it, I wouldn't have dropped this antibody, right? So I'd have kept that therapy going, and I would have waited, maybe indefinitely, for this to drop. But so there's 2 good messages of hope here. One is you could avoid this by doing your cross match now with the beads. And 2 is if you're doing a transplant and you should see this situation, you should keep giving something to block complement. So that's really good. The second case had no antibody, IgM. Third case had none. And then if you look at IgG, none of the animals had significant antibody. So that's something that's really a positive development. So now you know that SLA antigens are likely to be important targets for rejection, and that individual deletion of these molecules is feasible, and that recipient sensitization to SLA antigens likely leads to very early graft loss. Transplant of class 1 and DR knockout pigs can achieve prolonged function, and recipients of pig kidneys with SLA deletion are not prone to increases in infectious complications. So we've screened, so rhesus monkeys, CMV is endemic in them. So when you give any immunosuppression, the CMV reactivates, and I have figures if somebody wants to see them later that we can go through, but they had no CMV reactivation. The FDA is pretty concerned about when you start messing with the MHC, is that going to make the recipient very compromised? But remember, it's just their kidney that doesn't have it. It's not the whole body. I forget that, and I got very nervous. But also, we test for other things. So JK virus, which is the BK equivalent in rhesus monkeys, we did not detect any of that. The RSV40 we didn't detect. So we've looked for a lot of viruses, and we have been devoid of those. So now large-scale cross-matching is going on using the beads so that we can determine, do we want to do a DR knockout? Do we want to do a class 1 knockout? Do we want to mix DR and DQ together? And so if you were, again, now remember what I told you. My next correct prediction is going to be number 1. So take this with a grain of salt. But for sure, we're going to go in with a gal knockout. We're going to do the SDA antigen. So that's the beta-4-GLNT2. And this is the SEMA. knockouts on N-glycolyl acid, and basically it's this hydroxyl group right here. That's the only thing that's different. Pigs, everybody else has N-acetyl acid, and it's interesting. They say that 5 million years ago, we deleted that gene because it conveyed protective immunity to the prevailing species of, it's a common, I forget which, that's not diphtheria, but it's one of the viruses. Now, I got to be honest with you, I can't imagine people being around 5 million years ago. I'm not that, but that's what they say. So, malaria, it provided protective immunity to malaria. And so, but in any event, so our pigs are going to also be devoid of, for sure, DR, and then we're going to consider doing these. So what we've applied to the FDA for is to get approval to do what you kind of call an umbrella trial, right? So an umbrella trial, you take a disease entity that you want to impact, and in this case, it's end-stage renal disease, and then you have multiple therapies you can use. So we want to test DR knockouts, we want to test class 1, and then I want to test class 1 and DR. And we have elected to use the expanded IND access because we would like to take a couple shots at this and make sure that we don't do anything that we think, God, we should have been able to do that. Because if they say you can do 6 cases in your trial and you make errors due to inexperience, then now your 5 for 6 is as good as you can be. And then after you're done with the second dumb thing you've done, now 4 for 6 is the best you can be. So we're going to start with 2 DR transplants and see how those go. If I like how that's going, we'll do more. And then if I don't, then we can add class 1 on. I think class 1 and DR is going to clear the slate for most people. And then, so that's kind of where that's going. But so in conclusion, so donor-specific antibodies are still the major impediment to clinical application. Genetic engineering in the donor pig can eliminate these antigens, and we think the focus should remain on glycans and SLA molecules, and that detailed histocompatibility testing can identify recipients likely to have early graft failure. Prolonged survival can predictably be achieved in appropriately selected recipients without drastic immunosuppression. Clinical xenotransplantation is absolutely going to benefit from the use of newer and more detailed histocompatibility testing. And I should say yesterday, Stan and I had a really nice talk, and actually Toledo's going to get involved early because Stan's been looking at, what eplets are, and well, actually it's the electrostatic charge differences between donor and recipient. And so he's agreed we're going to send him all of our swine leukocyte antigen data, and then we're going to send him various recipients so we can try to figure out who, even though it's not a great match, who's got the best one. So that's going to be pretty exciting. I'm pretty excited about that outcome. So the ideal donor pig is going to continue to evolve, but needs to be centered around reducing xenoantigenicity. And routine clinical success is very unlikely if we ignore these things. And so what I would tell you about this field is enthusiasm is not your friend, okay? You have to be very cold and calculated and careful because you're going to get so many shots. I think we can do this. But you have to do it where you have everything lined up, tilted toward being successful. And so with that, I'm going to thank the people in my lab and the University of Miami have been so great, and Andrew Adams, who we've collaborated with for the last 15 years, and the people from Makana Therapeutics, who've done such a great job. My brother Matt's the chief scientific officer. He's actually the smart one. I'm the pushy one. And then, we got Chris Burlak, who's, I think a lot of you probably remember him from here. And with that, I'll take any questions.
Great talk. Yes. Stan.
Thank you very much. It's absolutely fascinating to see that xenotransplantation become actually in reality in a way that you can see that that's eventually good. But I have 2 questions. First question I have about monkeys and humans. Accordingly to the state of the art in human transplantation, you select recipients that do not have memory cells. Simply, they are primary challenge cells, and because of this, you can immunosuppress them comfortably with tacrolimus, sirolimus, and all of this. In your studies, meaning that they have antibodies, meaning that those monkeys and eventually humans that you presented, they already had memory cells. What means they had to have it because they produce antibodies. My question is, these memory cells, T cells and B cells, and these antibodies, those are cross-reactive antibodies because they've never been exposed to SLA antigens, right?
Correct.
Am I correct? And
yes.
Your intention to do knockouts is basically to eliminate the possibility that those memory cells can actually be activated if there is no HLA class 1 or HLA class 2 antigens.
Correct. That's exactly right. I mean, long term, and so we have cells that we could make pigs with, but I'm sure you can imagine, I'm doing it in downtown Miami, so I am a little bit confined with pig space, and I'm sure everyone knows what's going on in the world of science and funding, but we're waiting a little bit to get some of that chicken from the tree again. But we have cells ready to go that have no SLA, but have HLA DR4 and HLA A2. And so what we think we can do is create pigs that have a limited HLA match to you, so that the thought is, and we're going to have to test this, but if you have that the the level of antibody immunosuppression you're going to need is probably going to go down significantly. So that's I think most of the focus for quite a while is going to be on the MHC.
And the second question is the reverse interest. If you now have cells that have no class 1 or class 2, isn't this increasing chances for viral infections, and that would create another major problem, or what do you think about this?
Yeah, so that's also a great question. So our first set of class 1 knockout pigs were born in the middle of the porcine endogenous diarrhea virus pandemic. And so I'm going to repeat it. Porcine and diarrhea virus, okay? So if you can imagine, it was everywhere. And so I thought, God, these pigs are going to be born and they're going out tomorrow. We had 2 litters, 11 pigs. One pig was like 300 grams. They're supposed to be, about between 800 to 800 grams to 1.5 kilos. So that one was small and that one didn't do well, but the rest of them lived to be 600-700 pounds. So sometimes I say whatever I learned about immunology, I didn't. So when we looked at these animals throughout the course, some of them had low levels of antibodies, some of them had very high levels of antibody, and some had totally normal levels. They had normal reactivities to things. They made antibodies to vaccinations. And so from that perspective, we just haven't seen that. It's not what I would have expected, but it is what we've seen. The class 2, I also thought that was a problem. That's why we didn't knock out DR and DQ together, is because the mice were sick, right? Class 1 knockout mice were not sick. Class 2 total knockout were sick, so we didn't do that. But even they haven't had the problem. And then the issue becomes, the other thing is, so there's 55 viruses our pigs are not supposed to have by the FDA. So we have digital droplet PCR platform for all those. And shockingly, we were able to raise these in an academic vivarium to meet medical grade, which is great for us because we were able to break our contract with the facility, the barrier facility that we were paying $60,000 a month for, and just raise them in the University of Miami. So now our first pigs for trials, we're going to raise out of the University of Miami, and they're just going to have the pathogen screening and go. But so we haven't seen any of those problems. And then when you put the organ into somebody, you have to remember, it's just their kidney that doesn't have that, right? The rest of their body does. So, and also people ask about NK cells, like in the class 1, we didn't see that. We've had a hard time showing that. So I can't explain it, but I can tell you that's what our data shows so far.
Then the pigs are kept in the viral-free environment?
They're kept in a clean environment, yeah. I mean, we wear masks, we have gowns, and we shoe covers, wash your hands. I mean, it's like anything else. I think Shumway used to say cardiac surgery isn't difficult to do, it's difficult to get to do. And so I think, infection control is the same way, right? It's not difficult to do, it's difficult to get people to do it. And so, we have a small number of people, and it's very carefully managed, and we've had very few problems.
Thank you.
Hi. Great talk. Thank you so much. My name is Palmer. I'm a second-year medical student. I'm just curious as to, do you think your methods can also help to reduce T-cell mediated rejection in transplant as well?
Really great question. So I'm glad you asked it. So we've looked at that, and so when you look at the rejection, it's interesting. It seems to be that, so if you deplete CD4 and you leave CD8 alone, you get long survival. If you deplete CD8 and you don't deplete CD4, they go out in 6 days, 7 days. So it's like you didn't do. And then when you look at the rejection, it's all CD4 positive T cells. So now that's a great question. So when you delete the class 2 antigen, that's what the CD4 T cell binds to, right? And it turns out, this is another reason why we picked DR. 90% of the class 2 antigens on a cell, whether it's mouse, human, or pig, 90% is DR. Okay? In humans, DQ is 1%. DP actually expresses more. Would have never guessed that. But so what we're doing with the University at Cincinnati Children's is we're now looking at the number of T cells we got rid of, and we think that we got rid of 90% of the T cells that were going to bind to our graft. They're gone now. So I'm really glad you asked it. Now the thing about saying that is you have to prove it, right? And so we're running through our paces, but it absolutely looks like what you asked. That's exactly right.
So Joe, taking that question further and looking at your data, what you're presenting, I think is there a role for targeted complement inhibition where you don't have, even if you're antibody to antigen, but there's no binding? And there's no co-stimulation pathway you showed.
It's possible.
So
and we do it for the first 70 days, right?
Yeah.
Anyway, but it's totally possible. It might even be probable. The thing about putting the complement inhibitors on the cell surface is those molecules don't start reacting until you've already had 4 and 2 and 3B. And once 3B binds, factor B comes, and factor B is 1,000 times faster than the rest of the complement cascade. So that takes over. That's why eculizumab, the C5 antibody, doesn't always work, because sometimes factor B outcompetes eculizumab for the C3B. But I think that's quite possible.
Dr. Reese?
So where do you think the monkey that had 900,000 got sensitized?
Actually, that was a patient. That was the second patient.
Where did that patient get sensitized against?
Man, I don't know.
They had a CPRA of 0, so they
That's
didn't have
correct.
any antibody. You don't think, were they previously transplanted?
Yep.
Blood transfusions? Were they sensitized?
They didn't give me all that, but they had a PRA of 0. We retested them. It wasn't just, we didn't just take a word for it.
Do you have any idea what this is cross? Stan asked, you agreed it was probably a cross reaction. Do you have any idea what it's cross reactive to?
Well, now you're asking me to speculate. We've talked about my speculation skills. So, but here it comes. So if you think about when you're forming your immune system, there's all kinds of selection and deletion, right? So when you talk about clonal deletion. And so if you bind too tightly, it gets removed, right? Whether it's a T cell or whether it's a B cell with the antibody binds too tightly. So one of my guesses is that these are cells that it didn't bind tight enough, so they survive. And then probably got exposed to something that made it make a lot of IgM, but that's as far as I can go. And now you know, I'm starting to sound like Mr. Green Jeans, so I'm going to stop there.
Mike, there was a very nice paper, I think we reviewed, I can remember, how the exosomes can contribute to your HLA sensitization. And the exosomes even from the GI tract. So when we do the ExoDx test for the prostate cancer, these are the exosomes that are released by your prostate and the cancer cells. When the company was developing it, there was a paper that was published that in humans they found some pig and chicken ExoDx floating around in their serum. And they could not explain it, where they are very specific exosomes that are coming from. And it was the gut route through which exosomes can get your RNA, DNA into the stream and sensitize it. So I think ultimately, like you said, these are
That's a
mostly
great
startup
point. Yeah, so we've developed an assay. So we can diagnose AMR in real time using exosomes. So you basically just do a cross-match of exosomes. And because that's what happens is, so bad things happen to the cell, and the cell's smart, so it starts blabbing them off, right? So if you can grab the exosomes and see what's on them, then you can figure that out. And so we're talking to, Thermo Fisher is pretty interested in that assay, but you can diagnose it within hours, right?
That was actually Thermo Fisher's.
Yeah, that's exactly right. Yeah, no, that's a great.
You are what you eat. Ultimately, that's what they're saying.
That's why you're so skinny.
Questions? What a fascinating talk.
The heart transplant which got done, so did they not do a cross match at all before that? Because I mean,
they did.
Cross match that you said was quite positive. So, but why did they still proceed and did the transplant anyways?
So I said a bunch of things in it that will apply. Enthusiasm is not your friend, okay? So, because here's the problem. They say, oh, he is going to die. And we're all going to die, but here's the thing. He did die. Only he died with a transplant, right, in an ICU with a lot of other suffering that maybe, for me, I wouldn't want to do that. But they did a cross-match, so, and this is a challenge. So they use endothelial cells, right? And so to do endothelial cells, you got to put, endothelial cells have to sit on a surface. So they have to be in culture for a few days. So the first thing you need to know is when you put them in culture, they lose class 2 expression inside of 36 hours. So you can't measure those antibodies using this. So that's the first thing. The second thing is they throw things in there like bovine serum albumin, right? So bovine serum albumin has a lot of Nu5GC, right, which is the SEMA, is the second antigen that we had knocked out. And the cell takes that up and puts it back on the cell surface. So now you've created, so your background is so high you have no discriminatory ability, right? And then the other piece that you'd have no way to know is they used immortalized cells. And so if you think about it like a cell biologist, an immortalized cell, what does that mean, right? I mean, in any kind of an action hero movie, the immortalized guy is what? You can't kill him. So to do a cross-match looking for cell death in an immortal cell, that's a really low yield proposition. And so they said, look, there's a much better cross-match. It went from 4% killing or 8% killing to 4%. That's because the cell was too strong, right? And then the other part is they had complement inhibitors on there, which also downregulate. I mean, there's a whole bunch of, it becomes a very, it's like falling down a set of stairs, right? With each bump, it's going to hurt more. And so that's why you have to be very, very circumspect about where you start.
Oli, go ahead.
I've heard your talk a couple of times now, and every time I hear it, I feel like I'm learning more and more, and it's just exciting. So again, thank you. I'm going to ask you to speculate. And so in terms of speculation, there's been a lot of talk, a lot of work done around tolerance. Tolerance and transplantation. And so, when I look at genetic engineering and looking at xeno, is there a way to incorporate tolerance as we sort of think forward?
Yeah, I think absolutely. So thank you for your kind comments first. But so if you think about the development of transplantation, I think I've outlined it in 5 steps. So somebody told me, gosh, Joe, you should quit. You're not really making any progress. And so it was someone I thought a lot of, so it kind of hurt my feelings. So I went back and I looked from the beginning of time. And I realized from the time Alexis Carrel won a Nobel Prize in 1912, where he knew the following things. In the absence of technical failure, isographs always work, allographs never work, xenografts never work, okay? So that's 1912. It wasn't until like 1950 that they even started talking about immunologic rejection. So, okay, so I'm not doing that bad, right? So that was, but so the first step is, can it work at all? The second step is, can it work in a human, right? And so that's the identical twin experiment. The third step is, can you do it in most people? That's Imuran and prednisone, that's cyclosporin, tacrolimus. So now you can do it in most people. So now, where I think people skipped a step is, now can you do it in everybody? That's xenografts. Step 5, in my mind, is can you do it without giving any medicine? And the thing is, if you think about it, xenografts are going to go from a disadvantaged position to very quickly they could be in a very advantageous position, because now you can change the donor before it goes in. You don't have to do draconian things to your patient. But also, all of these things that we're learning to do, cutting genes with scissors, you can apply to cells. So now, instead of giving tons of medication and doing horrible things, you can engineer the recipient a lot. So that's the putting MHC, those kind of things in. But then you can start engineering the cells, right? So you can say, okay, I want to take your CMV immunity, we're going to soup it up in a dish, and then I'm going to knock out FK binding protein. We've made these cells. And so now you can have levels of 100 nanograms per mil, right? Roughly 10 times what you'd give a person. And those T cells act like there's nothing there. So you could take a person with bad CMV, give them their own cells that aren't going to go after the graft, and use a ton of Prograf and not pay a penalty from that perspective. And you can do that for any number of different viruses. We've also made pigs that can't get FK toxic, because I was so sure we were going to. So we gave them, I think, what was it, 4 grams of tacrolimus. We got no seizures. We got, grams, okay? I mean, it took like 3 or 4 months for them to assemble this so I could infuse it at once. But so you're going to be able to do a lot of very, very fine things. But it's going to be cells, your engineering of the recipient, and the pig. So I think in that light, I don't think tolerance is going to be in great shape until you can do all that.
Mike?
So Joe, following up on your idea, how do you transplant everybody? Your idea is to start by doing your beads and finding people that don't have much antibody, and that's where you should do the first experiments, because it's likely to work. But that's probably a small percentage of the population that are going to be the right people to pick. You and I have sort of talked about how you see being able to produce enough pigs, and you said that cloning probably isn't the way to do it, but rather breeding. So if only a few people don't have pig antibodies, and you test them and they've got antibodies, but you're trying to do breeding instead of cloning, how do you see making this available to the masses?
That's a great question.
Great question.
And it's one we thought a lot about it, we haven't. So I told you there's 2 kinds of antibodies so far that we've been able to figure out, right? And so in allotransplantation, I think there are 3. There's glycans, blood group, there's MHC, and then there are these anti-endothelial antibodies, right? And so like the ATA1, the endothelin receptor A. So we went and found all of those, and we knocked those out in cell lines, and we can tell you which ones are and aren't antibodies. So that one, if you have those antibodies and that's a problem, that's a pig. 1 gene knockout, you're back in the game. As far as the glycans, so we've created a pig CRISPR library with a collaborator at the Roslin Institute in Scotland. And so it has 80,000 guide RNAs. So guide RNAs are like, so if you think of Cas9 from CRISPR as the rifle, the guide RNAs are like the sighting for the rifle, like where am I supposed to aim? And so it has 80,000. So it cuts 20,000 genes, each gene in 4 different spots. And so you put the library into these immortalized cells, and then we let it activate, and we have these dyes in there so we can tell which cells actually got cut and so we don't waste our time sorting millions of cells. But then you put serum on, and you put complement, and then you take the survivors, and from the survivors you sequence those cells and you figure out what got cut. And then you get a volcano plot. And so as I age, I don't like all kinds of newfangled stuff. However, and I thought, oh, volcano plot, that's dumb. It's not dumb. So when I looked at it, I was like, oh my God, even I can see. It was like you sunk my battleship, okay? So they had, here's your target, and there were all these genes around it that related to what the offending agent was. So we've got polylactosamine is the next big problem. It looks like, not big problem, but it's the next problem. And so there's 2 glycosyl transferases that we've identified, beta-3-gal NT5 and beta-3-gal NT2. Now, like I told you, I went after 5. It helps. 2 looks like it's going to be the answer. So I always go, my guess is always bad. And so I've kept my perfect string intact. But that pig actually was quite an improvement. So once we get these first pregnancies done for the clinical cases, we're going to go back and make these beta-3-gal NT2. So that's how we're going to deal with those. Because we use knockout-only genetics and we haven't added all these transgenes, and we didn't talk about this, but we have added transgenes. It doesn't change pathobiology or graft survival. Okay, and the transgenes sort independently. So if you look at eGenesis and United Therapeutics, the 2 big companies that are doing this, 1 out of 8 pigs that they produce will be clinical grade. Okay, so I'm going to repeat that. 1 out of 8. That's going to be hard to scale. But if you just use knockouts always transfer when you use breeding. So we got males and females. So we went to Smithfield Premium Genetics, right? So if you go to the grocery store and you're going to get some bacon, it's Smithfield, right? And so they have a really, really good genetics group. And so they did brother-sister mating for us. We took the pregnancy, aborted it. We sorted out males, females, blood group O, PERV C negative, and then we started SLA typing them. So now we have males and females that have the same SLA, so there's going to be no switching. And then we engineer on that. So now we're going to be able to breed those. And so then instead of having, so when you do a cloned litter, you need 300, you start with 300 oocytes. That's 30 to 60 female pigs worth of ovaries. So if you can imagine for one pregnancy to produce 1 to 4 pigs, right? And so that's, how do you scale something like that? That's going to be incredibly difficult. But these things, the pigs, they'll breed and they're going to have, we pay a little penalty because they're brother-sister, but it's not what you would think, right? So the Smithfield farms have 16 to 18 pigs a litter. We don't want to raise 16 to 18 medical grade pigs at a time. That's too many to keep them all clean. So, these have been between 8 and 12, so that's more manageable. And actually, I'd like it to go a little bit more to, 6 to 10 per litter. So I think from a scale standpoint, we should be just fine. Yes, sir.
Hi, I'm Robin, PGY5. Thank you for a wonderful presentation. I was just wondering for these ELA1 knockout organs, do they have any defects in terms of functionality or longevity?
Zero. Can't find one.
How are they compared to live donors or deceased donors?
Compared to?
Live donor organs or deceased donor organs.
You mean human?
Yeah, human.
They're a little bit less proven. So that's going to take a little bit of time to sort out. But my expectation is that we can get into the clinic, and I'm going to be disappointed in myself if we can't get a couple of years of survival out of our first patients. That's my intention and goal, and I think that we can do that. And then I think it's going to get better and better. It's because if you look at allotransplantation and how that got started, man, we made a lot of mistakes, right? And the world was a lot more forgiving, right? But I mean, the thing is if you read about what happened in medical history with what you're doing, it gives you so much insight as you go forward, what can I do to avoid some of those problems? And I think we're really duty bound to make sure that we avoid all those things. So we have tried really hard to avoid all those issues.
Wonderful. Let's give a big hand. Thank you very much. That was wonderful.
Thank you very much.
And take a picture. Thank you. There's one announcement. The CME code is 19352. The one you got before was not working. I think that was because it was changed. So if you need that CME credit, please get to 19352. I think next thing on the agenda is faculty and residents are going to have a department picture. So we're going to go outside and get a picture taken with Dr. Kropp.
Not at all. Oh, no, I really enjoyed it. Thank you very much. Really? Great, and I will definitely send you the stuff. I'm pretty excited to do that. Oh, thank you. Very nice to meet you. So the monkeys are actually in Minnesota. So we have a big we have a cooperative grant with the through the NIH, and so we make the pigs. The truth of the matter is I mean the monkey work is really important, but the most important thing is making the right pig. And people skip that one because everyone's like, oh, I can sew it, I can operate on a monkey, but I think we're getting ready to start. So I have approval to put pig livers into brain dead people, to 5 of them. I'll probably do some of that in Miami. I might do some in Indianapolis, but we'd fly. But I mean, if you're interested, you should tell me.
I'm actually doing my urology AI at Miami. I start
Okay.
this week.
You should come visit the lab.
Where is it?
8th floor, Rosenstiel Hall. Rosenstiel? What are you working at UM or are you working at Jackson? So it's right across from Jackson. It's like about 100 yards from Jackson.
And the CRB, that glass building?
Here, you have your phone, right?
Yeah.
And you're much younger than me, so I'll give you my contact. Okay. Now tell me who you are, because my phone, when you do it, because my phone got hacked, and so I put the spam software on there. Freaking Donald Trump is harder to get a hold of than me now. It blocks everything. It's so terrible. I turn my phone off.
No, you're good.
It's a great way to get some peace.
I just wanted to, I think you gave a talk at the USTRS.
Yes.
Yeah, okay. I was there 2 years ago, or it was
Okay.
a year ago, so great talk.
Actually, it's different.
Yeah.
I gave a different talk. It's not the same.
Yeah.
We make some progress.
Yeah.
Here, you want to do the phone thing?
Yeah.
Hey, Joe.
I love this thing.
In 2 minutes, if you can come up for a
Yeah.
photo. Keep talking.
Can I leave my stuff here, or do I should come out?